Good morning, everyone. Myself, I am Dr. Jagadish, moderator of this international virtual webinar on autism spectrum disorder. I welcome you all to this international webinar on autism. Today, we are all gathered to spread the awareness on autism among medical and paramedical professionals. I would like to first thank our Institute and Department of Pediatrics, Apollo Institute of Medical Sciences and Research, for supporting in spreading awareness on autism every year. Let's welcome our eminent speakers who have joined hands and supported for the cause. I would like to begin the webinar with a brief history of Autism Awareness Day. The United Nations General Assembly unanimously declared 2nd April as an International Autism Awareness Day to highlight the need to help improve the quality of life those with autism spectrum disorder so that they can lead full and meaningful lives as an integral part of the human society. In 2008, Convention on the Rights of Persons with Disabilities entered into the force, reaffirming the fundamental principle of universal human rights. Autism is a lifelong neurological condition that manifests during early childhood, irrespective of gender, race, or socioeconomic status. Every year, to make people to understand and accept people with autism, foster worldwide support, and inspire people, it is the month, that is April month, that spread kindness and autism awareness. If we look at the prevalence or incidence of the autism, as per the World Health Organization, WHO, it is estimated that worldwide about 1 in 270 people has an autism spectrum disorder. One study stated that 1 in 66 children was autistic in India. Despite being an alarming issue, autism awareness is severely lacking, though its incidence has increased over the last decade. Autism is a neurodevelopmental disorder characterized by deficits in social and language communication, as well as repetitive behaviors and restricted interests. Some people cannot speak at all, and many have delayed or limited verbal communication. Some are greatly impaired in their cognitive thinking, while others are extremely gifted or outstanding performance. During this pandemic period, there is a lot of impact on autism community, like challenges in the areas of education, vocation, home, leisure, healthcare services, therapies, and behavioral services. Now, I would like to introduce the first speaker of the day, Dr. K.S.Multani, sir. He works for Air Force Hospital, Halwara, Ludhiana. His main areas of interest are developmental pediatrics, developmental neurology. He is the National Secretary of Indian Academy of Pediatrics chapter of Neurodevelopmental Pediatrics for the year 2020 to 2021. He is also Joint National Coordinator for TOT for Neurodevelopmental Disabilities and AAA and PSPP. I welcome Dr. K.S.Multani, sir, to take over the session. Thank you very much. And he will be speaking on IAP National Guidelines, that is Indian Academy of Pediatrics National Guidelines on Autism. I welcome Dr. K.S.Multani, sir. Over to Dr. K.S.Multani, sir. Thank you.
Thank you, Dr. Jagadish, and good morning, one and all. At the outset, I would like to thank the organizers for helping us in this of spreading awareness of autism to all corners, and I think they have done so well in getting national as well as international speakers for today. The task given to me is a very important one. One is that is the opening batsman. I think with IPL going on, this will I'm the opening batsman for the day, and the topic is overview of the consensus guidelines which were published by the IAP in the year 2017. Now, autism, as you all know, it's a neurodevelopmental disorder which is increasing in prevalence for last few decades, and this is big cause for concern because it affects early childhood, children who are developing. Now, affecting these children at such early time makes this a very major issue because it affects the learning during later childhood and the productivity of this child when he grows up into an adult. So I think it's a very apt topic and a very important topic for increasing awareness and catching them early. IIT took a lead in this in the year 2015 when they gathered a large group of people who were working in this field, and they started the work for creating the consensus guidelines for the Indian scenario, and it took almost a period of 1.5 years for these consensus to be made. And this consensus group consisted of pediatricians, developmental pediatricians, pediatric neurologists, psychiatrists, remedial educators, and clinical psychologists. And finally, these guidelines, they got published in the year May 2017 in the Indian Pediatrics Journal. And these guidelines are freely available on the net. Now, what these guidelines say, like I'll be very brief because to discuss the whole guidelines, it'll take long time. So I'll be only highlighting the important parts that are there. First and foremost, these guidelines say that all children should be development screened developmentally, especially at 18 months and 24 months, using a standardized autism screening tool. This is in addition to the routine developmental surveillance that a child undergoes during the well child visits and immunization visits. And if a child is below 18 months and parents have any concerns, it's very important to take a detailed developmental history, assess the social communication skills, and have a follow up visit after 3 months or 18 months, whichever comes earlier. And in the meantime, parental education and counseling should be done about what to expect in this child. This is because the aim here is to pick up these children early. Our target is to screen early, pick up early. Why this is important? We'll come to it later. Now, what screening tools to be used? 3 screening tools were advised. The commonest is MCHAT revised with follow-up, social communications questionnaire, and Trivandrum autism behavior checklist. Why this is important is if the screening results are positive. Now, this is not diagnosis. The issue is there is no laboratory test for autism. It is basically based on observations and screening tools and parent responses that we. So if the screening results are positive and they are high risk, early intervention should be started at the earliest. While if the screening is negative but parents are concerned, parents should be informed and child should be kept under follow-up. Now, once a screening tool is positive, now how do we diagnose? Then a diagnostic test needs to be done. The consensus guidelines mentioned some of these important tools which can be used, like Incline ESD tool, ESA tool. These are Indian tools which are developed, and international tools like CARS, Autism Diagnostic Interview, and Autism Diagnostic Observation Schedule. Now, all these tools are quite sensitive as well as specific, but some of them may not be free and they may not be available. Now, which diagnostic tool to be used should be based on your practice where you are available, and you should know where you can get these done. Once a child has been found to have features of autism, the most important thing is detailed examination and documentation. So detailed history is very important, in which the history for comorbidities. Now, autism is not a single diagnosis, it is a spectrum disorder. So it may be anything from mild to moderate to severe, and maybe having one or more comorbidities. So it is very important to take a good history to find out what all is there in the history, including detailed family history, detailed physical examination. Physical examination detailed is very important to look for any dysmorphic features, because a lot of genetic syndromes are associated with autism spectrum disorder, and many of genetic syndromes, they may have features which will make them look like autism, but they are autism mimics. I think this will be covered by a speaker later during the day. Another very important thing is that a child should be subjected to a good vision and hearing evaluation, because these are two systems which, if there's any disturbance, then this child who's a visually disabled or hearing disabled may have features like autism. And secondly, even in the management, a good vision and hearing is very important for managing these children. And a DQ IQ assessment should be done whenever, depending on the age of the child. Based on this detailed history, all this should be documented properly, because this is what will be, form the basis of the future management of the child. And based on this data, one should assess the child's strengths and weaknesses, because what we plan to do later is based on what are the child's strengths and build upon these strengths. Like I told earlier, there are no specific lab tests for diagnosing autism. So there is a very limited role, but this role is dependent on what we find in the clinical history and clinical findings. So based on the positive findings on the history and examination, thyroid function tests, EEGs, MRI brain and genetic studies can be ordered to find some additional comorbidities and also to prognosticate about the case. Now coming to this, what we all call interventions or therapies for autism. This is a very important field for autism, because this is what is going to make lot of difference. Now interventions have to be multidisciplinary. That is very important. There should be a full team, and this team should be led by a pediatrician who should coordinate the whole effort and coordinate the child and the parents between different parts of the team. Lot of different models are there, like behavioral model is there, then structured teaching is there, like teach model, which is treatment and education of autism and related communication handicapped children, or developmental relationship based model like floor time is there, or integrated programs like social communication, emotional regulation and transactional support. These are there. So depending upon the availability in your area of a specialized person or in your team, the child can be given a program. Now, what program we have to give should be based on the child's age and clinical condition and the family needs. Ideally, it should be a 1:1 child therapist ratio by a multidisciplinary team, which will give the best results. Most important thing here is that the parental involvement, that is family involvement, is very essential, because the child spends a lot of time with the family. Another thing which we have to understand is that this therapy that we are saying has to be a committed one, because it is not a short term one, it is a long term one. And research has shown that almost 25 to 40 hours per week of therapy is required to get good results in these children. So based on all this, it's very important that every child is given an individualized education plan, and the program goals should be these: improved eye contact, social interaction and communication, both verbal and non-verbal, reduction in the repetitive behaviors, improved sitting tolerance, improved joint attention, improved social, motor and behavioral capabilities, and empowering parents. Because only with this, the child, we can lead the child on a good path where he'll learn to be a good student and later a good person in life. In addition to these therapies that we discussed, pharmacological therapy has got some role, though there are no drugs as of now for core symptoms of autism spectrum disorders. So there are no drugs which affect the core symptoms. The core symptoms of autism are limited social interaction and repetitive restrictive behaviors. Most of the drugs which are there as of now are mainly for the comorbidities. And because they manage the comorbidities, they end up improving the overall child's performance and child's functioning. So medicines, if they have to be used, should be used in conjunction with the intervention therapies that we discussed earlier. I'll just take some time to discuss what all drugs are were there in the consensus. Like for attention deficit hyperactivity disorder, which is a very common comorbidity, methylphenidate is the preferred drug of choice. For maladaptive behaviors, risperidone is the drug of choice. For repetitive behaviors and rigidity, SSRIs can be used. For sleep related issues, melatonin can be used. Most of these children have got a lot of GIT related problems because of either feeding issues or constipation or colic. So the routine drugs which we use in normal children for constipation and colic can be used. A lot of these children also have anxiety related issues. So behavior therapy should continue for this also, and busuprone can be used. Mood disorders can be treated by atypical antipsychotics, SSRIs and mood stabilizers. And depression has to be looked for and managed with antidepressants. I think Dr. Jeeson Unni here is going to talk later in the session. And I think the best advice whenever using pharmacotherapy in a child with autism spectrum is to start low and go slow and see how you are causing the change. Now we live in India. India is a land of multiple different types of medicines. So the consensus group, consultative group which sat, they discussed a lot of complementary and alternate medicines which are there, which were discussed: diets, multivitamins, omega-3 fatty acids, pre and probiotics, chelation therapies, hyperbaric oxygen therapy, stem cell therapy, to name a few. But they could not reach on any consensus because of limited scientific evidence related to these different kinds of therapies. So the 2017 guidelines did not give any consensus on CAM, that means complementary and alternate medications. Now, what are the good prognostic factors? The consensus guidelines said that early detection is very important for a good end result. Children who have mild to moderate symptoms also end up having good result. Children who have functional play skills will have good results. Children who during the course of therapy develop communication and language skills and have high IQ, they'll also will have better results. And those who show good response to the IEPs, individualized education plan. And not to mention that parental involvement and inclusion of the child in the society. I think this will go a long way in having a better prognosis for the child. So the consensus ultimately ended up giving the following recommendation: that interventions should begin early. That means whenever you suspect and screen, if a screen is positive, don't wait for the diagnostic tool to come. Start intervention early. Definite diagnosis is not necessary for commencing intervention. Intervention should target the core features, like I discussed earlier: deficits in social communication and interaction, and repetitive restricted behaviors of the child. And the management should be by a multidisciplinary team coordinated by the pediatrician. Management of comorbidities is critical for effective treatment of autism spectrum disorders. I think this is what I have to say for most of the consensus guidelines which were there. I think Dr. Jagadish mentioned now these guidelines, it's been almost 5 years and the guidelines are undergoing revision. Now, why this revision was thought for? A lot of data has come in last 5 years and it was thought prudent that we should look into this data and add any new scientific evidence related to diagnosis or therapy. Second is that in India, we had the revised Disability Act of 2016, which has come into play. So, like I did not discuss the disability certification, which was part of the 2017 guidelines for this reason only, that it's undergoing revision. And not to miss the, I think all of you will agree with me, we last 1.5 years has been quite difficult for all of us, and we have learned lots of lessons in the ongoing COVID-19 pandemic. And telemedicine has come a big way. The telemedicine guidelines were published by the Indian government in 2020. So keeping all these things in view, the work for revision of the consensus guidelines for autism management has been started by the IAP, and in next few months, I think we'll be there with the new guidelines, which will be more comprehensive and more in sync with the new laws and data, scientific data that we have. Thank you very much for a very patient hearing. In case there are any questions, I will take them now.
Sir, can you show the previous slide once?
This one?
Yes, sir. So by the why part of it, I just wanted.
We live in an evidence-based world these days. Like if you find that a lot of research is happening, a lot of publications are happening at different levels. So why, like the need? It is needed because how do you manage? Like the previous guidelines didn't mention anything about the online therapy. Last 1 year, our children, these young children who are having therapies in different centers, they were not able to attend the centers. Telemedicine guidelines have come. So all these things need to be put up as part of the consensus guidelines. And the Disability Act, that was the previous Disability Act which was mentioned in the guidelines, and a lot of other things are there which we are revising. So because of this, I thought a slide should be kept for this purpose.
Sure, sir. Thank you so much.
Welcome. Any other questions?
Thank you very much, Dr. Multani sir, for your presentation about the national guidelines on autism spectrum disorder. Thank you very much. Now I would like to call upon Dr. Shabina Ahmed Madam, and she is the national chairperson of Indian Academy of Pediatrics Developmental Pediatrics chapter, and she's a past president of IAP chapter Growth, Development and Behavior, and she's a member of ISP-CAN International Working Group on Disability, and she is a national awardee for child welfare in the year of 2014, and also national convener on the program on childhood autism for the year 2007, Indian Academy of Pediatrics, and she's a member of Autism Guidelines Census Committee of Indian Academy of Pediatrics, and she's the founder, director, Assam Autism Foundation, and she's the chief editor of Understanding Autism, IAP 2007, and also she conducts many advanced programs, Hansen LLI certification, ADOS 2 certification UK, and ABA certification Toronto, PGER Spheres UCLA certification, Naturalistic Teaching Turkey, and Geneva Center for Autism Toronto, Canada, Developmental Pediatrics CMC Vellore, Neuro Development KFM Pune, India. Thank you very much, ma'am, for your time, as you are from Canada, and you have given time for me, for us. Thank you very much.
All right. Can I have my slides, please?
Yeah, I am.
Yes.
Sure. I welcome Dr. Shabina Ahmed, National Chairperson, to speak about early detection of autism, present and future. I welcome you, ma'am. Thank you very much. Over to you.
Thank you very much. Thank you, Dr. Jagadish and the Apollo Group for giving me this opportunity to talk to you all on autism, and particularly during the Autism Awareness Month. And today, and thank you for the collaboration with the Neuro Development chapter. So today I'll be talking to you on the early detection of autism. What is the present scenario and what would be the future? Just briefly, I'll just go through, just as an introduction, the definition. As we all know that autism is a neurodevelopmental disorder. Can I just have the previous slide, please? And it challenges child development because it is mainly challenging the social, emotional, communication competences of this child. And as we know, it is behaviorally defined. Next slide. Next slide, please. And it is behaviorally defined, and basically we try to assess what are the behavioral deficits in the child and what are the behavioral excesses in the child. I will not go into detail with this because Dr. Kawaljeet has already handled. But what is important to know is that this whole group of children, the heterogeneous nature of the child, every child is different and every child is exposing a certain a deficit area or presenting in certain excess area. And the second point is the uniqueness of this problem is that the child, the development, as the child unfolds, grows, the whole symptomatology keeps on unfolding. And hence, it's been very difficult to identify how are we going to manage the child and when are we going to do the early detection. Next slide, please. Next slide, please. Next, please. Okay. Now, another problem that we have with with autism is the patterns of presentation at the time of presentation is very different. For some, they may present at early onset when the symptoms appear after birth. Then we have some which plateau. That means they have a period of normal development and thereafter there is some flattening. Then we have some children where it shows that there is some regression. There is some period of normal development and then it regresses. And then again, there are some delay. And even after achieving the milestones, again, there is loss. So as you can see, the patterns are different and the timing of presentation is different in different children. Next slide, please. And there's another problem with autism is that we see them, some of them as classical symptoms. Then some again we say with double syndromes. There might be Down syndrome with autism, Engelmann syndrome with autism. And then again we get some transient cases. Now we're beginning to see a lot of transient cases because once we detect them early, we start intervention. Again, you find that the child is growing out of autism. Next slide, please. The incidence, as we know, is growing. It's worldwide, it is about 1%. And in America, the CDC, it reports it's in 1:54. While in India, we have figures of 1:125 or 1:85, depending upon which methodology we are using for the survey. Next slide, please. Now, this is just an example of CDC, America, that from 2000 to 2016, there has been an increasing trend. From 1:150 in 2016, it's reporting to be 1:54. Now, this similar trend is globally, and hence this initiates that we have to change our outlook. Next slide, please. Okay, there's some problem with the slides. Next slide, please. So now our approach to autism has to be very different. First is that early detection, we have to focus on early detection. Second is we have to find out efficient intervention models. And then thirdly, we have to find out factors that facilitate the whole process of so that the productivity of these children is improved and our human resource development is better. Next slide, please. Now, there's another problem where the age of diagnosis. The age of diagnosis seen all over the world is earlier, the diagnosis was seen around 4.4 years to 6 years of age. Then CDC now reports that there is a decrease in level at the age of diagnosis, 3.8, while literature search has shown from 2018 to 2020, the age of diagnosis still remains at 3.5. Now, why are we concerned about this age of diagnosis? Is because there is always a gap between the parental concern, the age of diagnosis, and the diagnostic stability. And this is basically, as I told you, that there is unfolding of the symptoms of autism, and hence it escapes the normal and a normal identification process. And this is called the diagnostic odyssey. And this is also called the autism diagnostic crisis. Because as we all know, that the first 3 years of life is one of the most important periods of life for neurodevelopment. And this is the period that what we are missing. Next slide, please. So now, as we said, early detection is one of the pillars. Now, we know it is useful because it has shown that the earlier we intervene, the better are the results. And we know it is feasible. But however, it has been seen, early detection has improved family well-being, has improved access to autism-specific intervention, has reduced care costs, has improved productivity, but however, again, there are some controversies and challenges that are rising. Next slide, please. So the potential issues are that there has been a lot of classification errors. So this has been a problem where people have not taken up as a population identification. Next comes the burden of universal screening. If we know it's increasing, but we have not been able to take the burden of this universal screening. Next is, we know we need to detect early, but then again, there are no long-term study as to what is the outcome of the child at a later age. Then comes the variability of the existing tools that we have. Then there are factors acting as barriers. These are mainly societal barriers, the parental barriers, again, individual child barriers. So, next slide, please. To address early detection, American Academy of Pediatrics approved that we should use MCHAT-R, and it's more than two decades of use from 18 to 24 months. And the use is increasing because they have translated this MCHAT-R into availability in different Indian languages. But then again, it has been seen that the use of the MCHAT is not universal. When MCHAT was started, initially, the sensitivity was shown that it was 0.83 with specificity of 0.99. But recent studies have shown that the sensitivity has dropped down to 38.8% and specificity to 94.9%. So why was that? Because large-scale studies have been taken, and it's been found that those who have screened negative, those that have been screened negative are actually turning out to be positive, eventually being diagnosed as autism. Next slide, please. So now I'll just go through the MCHAT-R. The flaws that have been seen is that, as you can see, number 2, number 5, and number 12. Yes, if you say yes to that, then you find that these children are at risk. But most of the time, when we apply this, we find that if you ask, have you wondered if your child is deaf? They will say no, because he listens to music. Fine. Next is, does your child make unusual finger movements? No, because he has some other symptomatologies. So if we fix ourselves at just finger movements, then we miss out on this. Then again, number 12, does he get upset with everyday noises? Because all children do not get upset with everyday noise. So these are some of the issues that have been seen. Then again, number 13, 14, does your child walk? Does your child look at you in the eye? Parents have not been able to tell you exactly the communicative pattern that the child had. You often get wrong answers saying, yes, they look at me. They look at me when I change the dress. They look at my face when I'm giving them food. But they have not been able to exactly understand the communication. Hence, these are some of the thoughts that have recently risen. Next slide, please. So the controversies that have risen is that it has been validated only with white people and with Western child rearing. And some of the questions that we ask actually is not really understood by the parents. Then there is a lot of parental denial. So they may not give you the appropriate answers. Then again, it is very age specific, but we find that it's age specific 18 to 24 months to 27 months. But there are some children who regress after 27 months. And then hence we again get false negative. Then we find that the sensitivity and the specificity again is based on the emotional behavioral problems that the child might have, because most of the parents relate the problems of autism basically to the emotional behavioral problems and not to the communication problems, and hence we're getting a lot of false positive results. Next slide, please. Now, these are just examples. So could these be emotional behavioral problems? There is so much reactivity inappropriate to the situation. Next slide, please. So the factors affecting the variability is that the performance in specific population could be different. Second is the problems are arising because some clear set guidelines are given, like finger movements, and so set guidelines are given which may not be found in those children, and there is no room for partial, because some of them may be doing, some they say 10% maybe he is doing, 30% he is doing, so there is no room and no column for that. And then it has not been used as per the recommendation. Then there is fidelity monitoring problem. Then there is socio-demographic pattern problem, child characteristics. Parents are, they do not take it as a concern, as I have said, and it is the prevailing health system is actually not including the universal screening of detection of autism. Next slide, please. So to bridge the gap, the first thing is required is now the professional expertise is of paramount importance, because we must understand the presentation is very, very variable and it unfolds at different times. Second is we have to do active listening. When the parents are concerned, that means that's the first point that we have to listen to. Second point has been seen that probably we should do a multi-stage screening when the parents have their first concerns, and then again probably another one at 3 years of age. So two-stage screening should be done. Then next is, if you find there is emotional behavioral problems associated, then probably use of CBCL should be done along with the MCHAT. Then comes that MCHAT may not be answering all the difficulties of the child. Then gaze preference has been something that has been added with the MCHAT, because gaze preference is the visual fixation and eye tracking. If that is done, then they have seen the predictability value of the MCHAT becomes higher. Then again, spatial frequencies to face. Studies have shown that those seen at 10 months of age gives again high diagnostic stability at 3 years of age. So now the question is arising, does screening tools, we should screen them before 18 months of age? And then what are the early recognition signs of ASD that will lead to the cascading effect of the social, emotional, and language development in the child? So next slide, please. So these are some of the studies, and these are mainly from 2021, where we are actually thinking of early identification, present, future, and advances of early identification. So you can go through them. Next slide, please. So now, this is a screening tool that the Indian Academy of Pediatrics from the Neuro Development chapter has come about, and I have developed this with my teammates. And basically understanding the gaps that are happening with the MCHAT, this is why we came up with this. So this tool actually we have divided into two. One is for 18 months and above, and one is 3 years and above. And we're understanding that the developmental level and the presentation is different in two ages. Next is, as you can see, all the pictures have been given along in context of relationship, and it is mainly in the Indian context, because the behavior of these children, behavior alone will not do. It has to be understood in context of relationship. Next is, it is cross-cultural, and next is the anybody can use it, but at any level in Montessori school, Anganwadi, and especially even the grandparents can see. Next, we find that it will facilitate facilitate you ask when you ask the questions of MChat, then the pictorial, if you use it complementary with the MChat, you will find it is easier for the parents to understand what are the problems. And then in this we have written that 1, 2, 3 is most crucial, because we are trying to find out what are the most important basic problems in autism that is going to lead to the cascading effect. So this is what we have been trying to highlight in this. And if you go to this next one, age 36 months and above, here we have given it in a circular pattern. We have tried to study, and this is developed with the IIT Design Department for Guwahati. And we tried to, how a person reads the chart, all that has been taken into consideration. And here we find that we have added 2 more. One is number 8, we have added imaginative play, and number 9, we have added the teaching pattern, and 10, we have added skills, because we have seen that symbolic play is something very important. And then it is very necessary that we try to understand the learning style of the child. This has been not included in the previous ones. And then we have to see the special skills, because the only way of taking these children forward, now early intervention is there, but we must have a focus on the skills that these children have. So next slide, please. So we find that number 174 concentrates on the social, number 234 concentrates on communication, 5, 6 concentrates on behavior, and 8 is on play, and 9 and 10 is on learning skills. And we feel, and our pilot study is being done, and we've seen that if it is used right now, it is not validated, so it cannot be used in an isolated tool. But when used in concurrence with the MChat, then we find that the predictability is better. Next slide, please. Next slide, please. So now I would like to thank these children, actually, who have been the main contributors to the development of this poster. Next slide, please. Next slide, please. Now, early detection is feasible, and we have to concentrate on what are the additional tools probably which can be used along with MChat. And then resurgence at relook of screening tools is going on. Probably we are going to try screening much earlier than 18 months. And we must know that the pediatricians play the most pivotal role. Next slide, please. And I would like to end with this slide. Now here, most of you must be knowing, we have been using their tools, Sandra and Timothy View, and most important is we have Dr. President Abdul Kalam. And why this is so important, and that is the time he said that probably all that it needs for autism is to develop a chip. And I do not know, probably we are going towards that now. Thank you very much for the patient hearing.
Thank you very much, Dr. Shabina Madam, for your presentation on early screening, autism early screening, and for autism present and future. Thank you very much.
Thank you.
Now I would like to introduce the next speaker, Dr. K. Pavan Kumar, who is a State Secretary of IAP, Indian Academy of Telangana, that is Indian Academy of Paediatrics of Telangana chapter. Dr. Pavan Kumar is also Associate Professor of Pediatrics, MNR Medical College, and is a consultant pediatrician of Omega Clinics, and is having fellowship in allergy as well as clinical immunology, and is a postgraduate diploma holder in pediatric nutrition, and also he is a postgraduate holder in diploma in early childhood development, and is an instructor for BLS, PALS, NRP, ATM, RAP, and ECD. And also he received Best Research Award for the year of 2016 and 2018 MNR Educational Trust. And also he received National Award winner. He is a National Award winner of Dr. B. Balagopala Raju Gold Medal for the scientific research paper in the year of 2010. Dr. Y.R. Reddy State Gold Medal, Dr. Chandrasekhar Chaudhary Gold Medal for the year 2009, and he received Vajratna Award for the year 2014. I welcome Dr. K. Pavan Kumar to talk about autism screening in pediatric practice. Over to Dr. Pavan Kumar. Thank you for joining with us. Dr. Pavan.
Thank you so much, Dr. Jagdish. Yeah, thank you so much. Thank you so much for that nice introduction. Dear pediatricians and all the faculty who are dealing with autism children, today I am going to, on behalf of Paediatric Academy of Telangana State, I am going to give my perspective on the autism screening in a busy pediatric practice. So, few years ago, maybe I think 4 to 5 years ago, before I attended the Neuro developmental disorders workshop, that's a TOT has been arranged by Dr. Samir Dalwai team at Bhopal. So till that point, I used to be a person, the pediatrician, seeing a busy OPD. But even though the autistic children are coming into my clinic, it was like I'm not able to recognize them. It is like what mind knows, the eyes only see that, right? So eyes only see what mind knows. Till that point, my perception, I was never known that such conditions exist, and we never studied in our practice. That is only for the examination we used to study. But the real timer, we are really missing in the clinical practice. They will come with the label almost all. It's after attending that workshop, it is now almost a gestalt diagnosis for me. So it is like more like, the moment the child enters, if I observe for 2 to 3 minutes itself, I can come to a conclusion that this child is high risk for autism. So that is the level of interest. And, if you have a high index of suspicion, any pediatrician can recognize this disorder much early. And dear friends, the autism is the most rapidly increasing neurodevelopmental disorder across the world. And pediatricians are going to get more and more cases in the future. As Madam told, the incidence is increasing. Now it has come to the tune of almost 1 in 100. So a quick questionnaire. If any of you can type in the chat box, it will be very good. So these are the true or false questions. Quickly we will do it. Is autism a speech problem? You can type in the chat box. No, definitely it's not a speech problem. It is the disorder. Yes, the child presents to you with the child is not speaking, but it is definitely not a speech problem. It is a social and communication disorder. Okay, second question. In majority of cases, autistic children look normal without any dysmorphism. Is it true or false? Yes, absolutely. They look very normal without much any dysmorphism. Only 10%, around 10% of the people only will have these syndromes. As ma'am told, Down syndrome, Angelman syndrome, Fragile X syndrome, and all those features will be only in less than 10%. And third question, is autism a type of mental retardation? Absolutely not. It's only a social and communication disorder. Their IQ levels are very good actually, and that means they don't have a very mental retardation. If you see, they will be more advanced. The way they used to handle the phone and the tab and the TV, I think it's amazing skills they have. So autism cannot be diagnosed before 3 years of age. This was a previous notion, but now as the madam is telling, you can suspect autism much earlier at 3 months. That is you can look for the features of autism, but definitely if an experienced person can detect the autism surely by 18 months, like a pediatricians for us, like us, I think we can diagnose autism for sure by 2 years. Some autistic children do not mingle, but some are over-friendly and go with anyone. Is it true or false? Yes, it is, dear friends, it is not a single sort of disorder, it's a spectrum. So a child who sometimes can have he doesn't mingle, there is a stranger anxiety will be there, and for some people there is no stranger anxiety at all. And all autistic children are hyperactive. Is it true or false? Need not be always. There are some most passive children also who are autistic. And milestones are most common, mostly normal or advanced in autism. Yes, motor milestones, definitely they are normal or advanced. I think the amount of dexterity or the amount of the way they handle the things will show that the motor milestones are absolutely normal. And are all autistic children have extraordinary capabilities? Definitely not. Now let us see the autism proper. So what is mean by autism? We all know auto means self. That is in his own world. The child lives in his own world. A very accurate description of an autistic child. That is,
Sir,
a child is
we
not
can't,
bothered about the people around him. He is
sir, we
mostly
can't see
involved in
any
his own
slides.
activity, which tends to be repetitive. So auto means self. That is, child is living in his own world. It is a very accurate description of the autistic child. And the child is not bothered about the people around him, mostly involved in his own activity, which tends to be repetitive, lone play, sustained odd play, purposeless, no socialization, no eye contact, no response to name, and does not communicate his needs. This is very important. Why we are repeating these words repeatedly means this should ingrain in your mind, because what mind knows only eyes can see. So before the pediatrician, before the child enters into the pediatrician chamber, even before entering your OPD, I think you may hear a high-pitched screaming outside itself, and the tapping of the shoes running to and fro repeatedly for a long time. And the older children who cannot even looking at you, they will enter. The once they enter into your chamber, they won't even look at you. They won't feel that you are existing to them. So they will just look at you and go straight to their favorite toy. And some will be repeatedly getting out of parents' lap, and their parents usually they hold them tight. So what we need to do is ask the parents to leave the child freely. Don't get paranoid. The child will go to his favorite toys. Then start taking history and candidly observe the child, keenly observe the child. Ask parents by what name he is called and call the child by his name. 90% of the time, by the time you finish the history, I think you have observed most of the symptoms. So previous slide. Yeah. So the usual presentation is there will be a speech delay and child not saying in sentences. The mother comes and tell you that there is a speech delay and all. Next slide. Yes, there is a lack. These are the red flags from the DSM-5 criteria. DSM-5 criteria has diagnosis. DSM-5 criteria. Yeah, DSM-5 criteria has grouped them into two groups, like impaired in communication and interaction, and another is repetitive behavior and restricted interests. So as a pediatrician, it is very important for us to look these red flag signs. So for a practicing pediatricians, I think if you remember these red flag signs when the child comes to your clinic, if you remember these red flag signs, I think that will be a great thing. So what are these red flag signs in two domains, especially impairment in social interaction and impairment in social communication. So the interaction, what I mean is lack of response to name. So when you call by name, it should not be so loud that child will turn to the sound, but it should be the name called gently. And lack of eye contact, lack of joyful expression, and no social smile, lack of sharing interest, and lack of non-verbal communication gestures, and extreme stranger anxiety or no stranger anxiety. Both extremes can be seen. Next slide. Yeah, I think for pediatrician, these red flags are very, very important. The impairment in communication, no back and forth cooing and social smile by 6 months, lack of joint attention by 9 months, not pointing or showing things by 12 months, not saying one word by 16 months, and not joining two words by 2 years. Dear friends, these are important milestones which you should not miss in your routine practice. Whenever the child comes for vaccination during this period, please have this in mind. Previous slide. Jagdish, when I say next slide, please change, okay? Yeah, so and they use the person's hands as a tool, and the jargon speech, the new speech that is called neologism, you won't be able to make out the speech what they are speaking. And there is a regression of speech for any social skills at any time is an important hallmark of autism. Usually parents says that the child used to say mama, nana like that, but now he is not saying doctor. So that is the regression of speech for any social skills is very, very important. And the earliest symptoms are not absence of normal behavior. So dear friends, please note this. It is not the absence of normal behavior. It's not the presence of abnormal ones, but the absence of normal behavior. That is what you should remember. Next slide. So coming to the red flags of repetitive behavior. Yes, these children with objects, they shaking thread, and they rotate wheels and any around things and stacking, lining, they will be very linearity, they will follow. And with their body, they will spin, rock, shake head side to side, jumping, toe walking, hand flipping, and finger twisting, poking eyes, grimace, head banging, and all these red flags are there. Next slide. Yeah, restricted interest. These children show little interest in toys or excessive interest in particular toys only. And they focus the parts of toys, like, just spinning the wheels of the car, not playing in the way that they have to do. And there will not be a pretend or play, imitative play. And the emotional regulation, if you see, they insist on the sameness and the distress over removing objects or changing routine and excessive tantrums. And these children will be very difficult to calm down when distressed, and there is an abrupt shift in the emotional states. Next slide. So this is what is very important. These red flags every pediatrician should have on this chamber table, and we need to do that. So what is the pediatrician supposed to do? Yes, he should screen the assessment for autism. This is our domain, dear friends. It won't take much time. A high index of suspicion will save the child's life here, because less than 2 years, if we are able to identify this condition, because of the enormous brain neuroplasticity, the results will be much better. And before labeling the child as an autistic child, make sure that you do audiological assessment, the hearing assessment, and also do some hypothyroid, rule out hypothyroidism, and also tongue tie, and some basic investigations which are intervened with the mental development, like iron levels, lead levels, like that. So early intervention is the master key here. Early diagnosis and early intervention is the master key, which will help the child to become almost near normal, and refer to a developmental pediatrician at appropriate time. Next slide. So yeah, there are 3 screening tools. We all know that Trivandrum scale and social communication questionnaire, and also the MChat, the famous MChat. The Trivandrum scale is our own. It has 4 domains: social interactions, communication, behavioral characteristics, and sensory interaction. They will be scored like this, and the results are any child more than 36 to 43. The score, if it comes in this way, child is labeled as an autistic child. So, and moderate, severe, like that also it can be labeled. Coming to the social communication questionnaire, which has 40 items, it has a parent reporting screening measures, and it should be recorded in a yes or no format. And the parent or caregiver can finish the task in 10 minutes, and the administrator, like pediatrician, will take only 5 minutes to score it. It is not suitable for less than 2 years of children. Next slide. Now the most famous, the popular one, Dr. Jagadish, next slide. Yeah. So MChat, this can be used between 16 months to 30 months, and the standard recommendation is 18 months and 24 months during the well child checks. And what you need to do, the first step, there are 3 steps involved in that. First, give the chart, MChat, to the parent to fill it. Yes, they will fill it in 5 to 10 minutes. And when they bring it to you, the provider, again, we should score it for 2 minutes. And if that score is positive, then select follow-up items based on the failed MChat R items. Next slide, please. So this is how the MChat R score looks like. I think Madam already clearly told Shabina ma'am that, like 2, 5, and 12, if they are labeled as yes, then that is the child is high risk for autism. They are at risk for autism. And all the other factors, if they are labeled as no, then they are at risk of autism. Next slide. These are 20 questions here. Next slide. So how to label the score? If the score comes less than 3, no follow-up is needed unless there is a surveillance or other procedure suggests the risk of ASD. And 3 to 7, administer MChat or follow-up. And the total score in the follow-up is more than 2, then refer to the diagnostic evaluation and early intervention. And if its score is more than 8, no need to wait. Don't say that, wait and watch policy is dangerous in this condition. You should immediately refer to the developmental pediatrician for diagnostic evaluation and early intervention. Next slide. So this is how it is being scored: low risk, medium risk, and high risk. It is being labeled according to that. So 2, 5, and 12, the response, except that if the response is no, that the child is labeled as a ASD risk. Next slide. So if the failed items only, we'll do this MChat or follow up. Each question has its own page. I think I request all the pediatricians to download. This is available free here, and it is easily available. You can download from this screen. It is freely available. Next slide. And once the screen is positive, take comprehensive history and physical examination, and definitive diagnosis should be done based on the DSM-5 criteria. Hearing assessment is mandatory. Most of the people who are deaf and because of deafness, they are not able to speak. There was deaf mutism. These children were labeled as a autism children. And exclusion of autism mimics, which we are going to listen from Dr. Srikrishna sir now, and look for comorbid conditions. But to look for comorbid conditions, history plays a big role. And always remember, if you are suspecting some genetic syndromes like Down syndrome, Angelman syndrome, Fragile X syndrome, you need to evaluate separately. So these are the specific, these disturbances, they need a specific evaluation. Next, ultimately, determine the child's profile of strengths and vulnerabilities and individual development profile. That is most important for the planning intervention. So always remember, don't look for the presence of abnormal symptoms. Always look for the absence of normal behavior. That is what is important in the autistic child diagnosis. Next slide. I think these are the diagnostic tools, DSM-5, INCLIN and ISA, and this was already told by our Multani sir in detail. What is the sensitivity, specificity of that? Why these tools are very important? Without these tools or instruments, the diagnosis can be made only in 30%. With just simply applying these tools like MCHAT or Trivandrum scale, the sensitivity, the diagnostic ability will go to almost 80%. So that is the power of using tools in these cases. I think with this, next slide. So these are the red flags in a nutshell. I think you can just a screenshot of this. These are the generally avoids contact. These are all there which you need to, which will be depicted in the MCHAT itself. So with this, I think I'll conclude on time. Thank you.
Thank you very much, Dr. Pavan, for your excellent presentation on early screening in the pediatric practice, which is very, very utmost important, where actually the children with the neurodevelopmental disabilities come over to the pediatrician. He should be in the position to identify, screen, then after he has to refer to the developmental pediatrician specialist for the assessment. Thank you very much for your excellent in-depth presentation. Thank you. Now I would like to introduce the next speaker, Dr. S Srikrishna, and he is the HOD, Head of the Department of Pediatrics, Apollo Institute of Medical Sciences and Research. He will be talking about the comorbidities in autism spectrum disorder, because the child definitely with autism spectrum disorder will be having many comorbidities. So he will be talking in detail what are those, and how the parents should be in the position to identify, and how the pediatricians should be able to identify or screen. Thank you, Dr. S. Srikrishna, for your presentation. Over to Dr. Srikrishna. Thank you very much.
First of all, I thank every speaker on behalf of Apollo Institute of Medical Sciences for participating actively in this discussion and CME about very, very important topic, that is autism. And second, I thank Mr. Jagadish for arranging this. So myself, Dr. Srikrishna, I am the HOD and Professor of Pediatrics at Apollo Institute of Medical Sciences, Hyderabad. And also we have a Sumedha Neuro Development Center at Apollo, and for which I am the head. Okay, now let us see what are all the different comorbid conditions associated with the autism. These are the big list, in fact, which is observed along with the autism cases, like behavioral comorbidities, medical comorbidities, and genetics related comorbidities, and even there's some radiological or structural defects also noticed. So these are the big list of the diseases which are associated with autism spectrum diseases, and some of them will give a lot of confusion also, whether this is what we are dealing is autism itself or something else. So when you broadly divide these conditions, the conditions which are commonly accompany this autism, they fall into 4 groups with varied intensity. One is a classic medical problems, especially epilepsy, gastrointestinal issues, or sleep disorders. There are more medical problem for which the medication is very, very important. So apart from treatment of autism, you are supposed to give even the medication also for these cases. Second are the development disorders, such as intellectual disability or language delay, for which the special therapies are needed. Third are mental health conditions like attention deficit hyperactivity disorder or obsessive compulsive disease or depression. And the genetic conditions that include the fragile X syndromes or tuberous sclerosis complexes. So what I have shown the previous big slide, it will broadly divide into these four groups. Okay, let us move on to them. How common are these conditions are among the people? So if you see that these conditions include that like ADHD, anxiety and depression are the most commonly diagnosed comorbidities, whereas the range of anxiety seen in autistic children, it's a quite big range is given in a different studies, and 11% to 84% also. And but the what is important, more important here is nearly all conditions that accompany autism can have serious effects on well-being. Unless you treat these comorbid conditions, many times you may not get the complete achievement what you are expecting from these children. And sometimes some of these comorbid conditions have more severe others. So the better understanding of conditions always improve the quality of life for the autistic children. So how co-occurring conditions might complicate autism diagnosis? This is a problem here, especially when the neurological problems or neuropsychiatric problems, if they are coexisting, they always give confusion for the diagnosis of the autism itself. Like some autism traits, such as poor social skills and sensory sensitivities, they may overlap with those of other conditions. Similarly, the people with autism and those with schizophrenia both have trouble picking up on social cues. Similarly, the ADHD traits also masked are mistaken for this autism. This is a common question. What we come across when the child of autism comes, they ask that is it ADHD? Similarly, when the ADHD children comes, they say that sir, is it autism? Because these are the two most common conditions. So the people also know them. So even their neighbors will tell that this must be that. So sometimes we get confused whether this ADHD or autism. And the delay when the child receives and diagnosis is very important. Autism is much early in presentation, and autism diagnosis may particularly tricky in people with intellectual disabilities or severe language delays. If there is an associated developmental delay, definitely it is difficult for us to assess the autism child properly. So when you are assessing these comorbid conditions, sometimes we pose a problem, because usually we know that nowadays for ADHD there is a separate scale, for sleep disorder separate scale, for epilepsy separate scale. But when they are comorbid or coexisting with along with the autism, these scales may not be the specific scales which we use may not be used completely useful. So the screening instruments designed for the psychiatric conditions in the general population may not adequately differentiate features of ASD, and sometimes it may give overdiagnosis or underdiagnosis also. This I have seen in many children, because they fail to recognize the other coexisting conditions, and they may overdiagnose also. So there are some several, but what is the thing here? There are some specific validated autism specific scales have been there, and especially developed to assess the comorbid disorders in children with and adults with ASD. So what are those specific scales for psychiatric comorbid conditions in ASD? Though these particular these below told the obsessive compulsive scales, they have separate scales for obsessive compulsive disorders. But for the child with autism, this is special, like A.L. Brown's obsessive compulsive scale, and repetitive behavior interviews, and some repetitive behavior questionnaire is very needed, and parent rated anxiety scale for youth with autism spectrum disorder, that is a PRAS ASD, and ASD comorbidity for adult scale. This is used for the adults. And some children with the anxiety scale for children with ASD and anxiety disorders interview schedule with autism spectrum addendum. That means they have special scales are there, especially useful for the children with ASD, which whereas in general what the scales we use for this that specific diseases may not be useful in this condition. So this is very important point. These special scales we need to remember whenever we are dealing with autism child. Now let us come to the in brief treatment. The treating a related condition may also ease a autism trait sometimes. For instance, treating seizures may decrease cognitive and behavioral problem. We know that any child with repeated seizures may further his behavior changes and even his development, neurodevelopment changes also see. So if you and was already autism child and with this because of the recurrent seizures there is a further developmental changes, then it is much more problem for us to deal with this, such children. So you should treat the children with seizures, and it may because if you don't treat, then it is a problem to treat even the autism children also. Similarly, the sleep disorders and gastrointestinal problem sometimes may also offer behavioral benefits. So the sleep quantity and quality can also affect the mood and the severity of repetitive behavior. So in these conditions, medication are needed. Usually for autism, not particular medication is needed, but we should not be too uh, feel that there is no medication at all, because if there is a comorbid condition, unless we treat that condition, we may not get the complete relief what we are expecting from the child. Now let us come to the individual system related diseases. These are autism and gastrointestinal disorders are one of the most common complaints. Even in my day-to-day practice also, I've seen many children with autism, they keep coming. Here the GI disorders are seen in almost 8 out of 10 children with autism spectrum diseases. The common GI disorders are chronic constipation, abdominal pain, which is a non-specific most of the times, gastrointestinal, gastroesophageal reflux, or the bowel inflammation condition. These are we have a separate topic about gastrointestinal disorders in autism children. So I'm not going into much details. Among that, and apart from that, because it is a very difficult for these autism children to explain about the hygiene, because some children they repeated they routinely they follow this hygiene, but some may not be caring because they keep on touching all the objects and again keeping the mouth or take the food. So there is a chance of recurrent gastroenteritis is very high for these children. Similarly, the autism and feeding or eating problems, because they are seen almost 7 out of 10 children with autism. So these are they have a big range also. These issues can include the extremely restricted food habits and sometimes total aversion to certain taste or texture also. So it became a difficult for the parents that sometimes I have seen the parents here beating the child and threatening him for not having particular foods. So, but this is more, we cannot point out that this is the reason. So we need to be very careful in dealing these particular feeding habits of these children. And some children may have chronic overeating and obesity, and pica also a very common symptom for these children. So these individual problems need attention, and we need to deal with them whenever the child of autism come to our day-to-day OPD. Now, what is the sleep disorders in autism? Here, over 50% of children with autism has sometimes, in some cases, there some reports say that almost 80% have one or more chronic sleep problems, like sleep for less time, or some children sleep for more time, excessive sleep, is there, and some children will have irregular sleep habits regarding time and place also. Sometimes they are the least bothered about the timing, like morning food time or afternoon food time. They may go for sleep. Sometimes when everyone is sleeping, they don't get proper sleep and they sit and they want to play at that time. Sometimes even the place orientation also, sometimes irrespective whether it's they are there at home or outside or in the going into any garden also. Sometimes they feel like irregular sleep habits also can be there, and even the sleep also disturbed can be there. I've seen some of the children coming that, sir, exactly the parents come and tell that, sir, exactly after half an hour to 1 hour he gets up and starts shouting, or he try to get up and very noisy and irritating behavior he shows, and again after some time he sleep. This happens for 2 to 3 months also. So the disturbed sleep patterns also common, and many adults are uh, on the spectrum likewise have difficulties falling asleep and staying asleep through the night also. These sleep issues tend to worsen behavioral challenges, as we know that those with the sleep disorders have a behavioral problems also, and they may interfere with the learning and decrease in overall quality of life also. And let us see one more the common condition, that is epilepsy. This epilepsy is quite common in the autism children. Almost 30 to 40% of children with autism can have a seizure disorders, and by contrast, even whereas if you see in the general population, it is seen in only 1 to 2% of the general population. That means seizure disorders or epilepsy is seen in only 1 to 2% of general population, whereas it is almost 30 to 40% among the children with autism. So as a red flag signs, as I already told before, that unexplained staring spells, involuntary movements, unexplained confusion, severe headaches, are red flag sign for this. Why I'm particular about this, we need to tell the parents that sometimes the movements what they observe in the child of autism, they may feel that it's a routine for that autism child, and they may not recognize the epilepsy also. So these are some red flag signs which they need to recognize, and always treatment of epilepsy is very crucial to prevent brain damage. And autism and attention deficit and hyperactivity disorder, that is ADHD. This is in general population. We found that 5 to 7% of general population will have ADHD, but in children, among the children with autism, almost 30 to 60% of children are having some features suggestive of ADHD also. It involves the persistent pattern of inattention, difficulty remembering things, trouble with managing time and organizational tasks, hyperactivity and impulsivity that interferes with the learning and daily life also. The symptoms, the main problem here is, as already I told you before, that the children, many parents get confused when we diagnose ASD. They tell that, sir, it is looking like ADHD. Sometimes the children with ADHD come that, sir, this may be autism. So here it is because the symptoms of ADHD can overlap with the autism. As a result, the ADHD can be difficult to distinguish separately from the autism also, spectrum disorders. And the treatment that includes the treatment of ADHD, as everyone knows, it is like a behavioral strategies, and sometimes some medication also should be given for ADHD. Now let us see the anxiety, how common it is. The anxiety disorders affects almost 42% of people with autism. Whereas in general population, they are seen in 3 to 4% among children and 15% in adults. That is, anxiety is seen in general population so less that it's hardly 3% in children and 15% in adults, whereas it's a 42% in the children with autism. So because people with autism may have trouble assessing and expressing how they feel, behavior often provides the best clues in those experienced anxiety. Similarly, anxiety can trigger like a racing heart and muscle tightness and stomach aches. Sometimes they come with some other complaint also. And there are some people with extreme fear of new people, that is social anxiety. Then whenever they go into the crowds and social situations also, and especially common in even children also, children with autism also. And some children may have difficulty controlling anxiety once something triggers it. So that behavior and very violent behavior also can be seen. Again, the treatment include the behavioral interventions along with cognitive behavioral therapy, which will be discussed later in detail. Rarely, sometimes you may need to use anxiety medication also. Then the depression. Usually in the common general public, it is around 2% among children. The depression is 2% among children and 7% among the adults. Whereas in autism, it's seen almost in 7% in children and 26% in adults. There are some condition with biological mechanisms with autism. The schizophrenia and bipolar disorders they share the similar gene expression patterns with autism. Similarly, the language difficulties or aggression also share gene variants and traits. Even the epilepsy also share the similar gene traits with almost more 8% than the common thing. What are the general consideration when the child with comorbid condition comes? Here, established a baseline, that what is an individual baseline for which he was functioning his best. And all these psychiatric conditions that are episodic or those which appear later in development, it's important to distinguish from this baseline behavior. That means in the initial stages only, it is better what is the baseline for this particular autism child. Then you can notice that what are all the other comorbid conditions which are happening in later life. Second, always assess the medical comorbidity and factors in genetics also. This needs an extensive study also for the behavioral phenotypes, and consider symptoms in the context of developmental level, like it should be considered sometimes that even according to the child's mental age also. So always, as everyone knows, this is always a multimodal approach, and like a treatment of comorbid psychiatric conditions in autism spectrum diseases, it warrants a multimodal approach with contribution from the caretaker education, that is applied behavioral analysis, psychotherapy, pharmacology, sensory, speech and language intervention, and other disciplines also, depending upon the individual history and presentation. Here is the field, these comorbid conditions, many of them non-neurological condition, essentially require a pediatrician and regular observation is very important in condition, so that the complete comprehensive treatment can be given. Thank you very much for giving this opportunity.
Yeah, I would like to introduce now Dr. Lokesh Lingappa, sir. He's a pediatric neurologist from Rainbow Children's Hospital, Hyderabad. I welcome you, sir, to speak about autism mimics. Thank you very much. Over to Dr. Lokesh Lingappa, sir.
Thank you, Dr. Jagadish, for this initiative. You have been working hard to bring the knowledge as current to the people who are involved in management of autism. So, I'll just. Is the screen visible?
Yes, sir. Done. Visible.
Yeah. Okay. So I think currently the previous speakers have spoken about the diagnosis of autism, the various comorbidities. As pediatric neurologists, when we see a child with autism, we want to be sure that we are not missing out on a different condition mimicking autism. That is one thing, because it is at the initial part of diagnosis, you should be very clear what we are dealing with. And later on, we will just go in the direction of therapies. So before the child goes into a hand of therapist and then the only therapies are continued, we need to establish a comprehensive diagnosis and rule out the comorbidities. So autistic spectrum, that's why it is a spectrum rather than a disease or a single entity. So large variations is noted, so we can accept large variation as part of the autistic spectrum disorder. So genetic disorders can also mimic autism.
and they can be many of the genetic disorders. Autism is a comorbidity, like tuberous sclerosis. Lots, almost 1/3 of them can have significant autistic traits. So this is where we need to make a comprehensive diagnosis. One of the thing essential is a comprehensive perinatal history, any high risk factors in the perinatal period, antenatal period, and the postnatally any epilepsy which is there, visual impairments, all those things have to be captured in the history. And good anthropometry has to be documented even in this group of children, because that can be a good handle in certain situation. Or in a recent study published in 2020, what they have noticed is relatively, most of them have relatively slightly larger head, but that can vary as compared to the age of the child and the sex of the child. So in this study, what they had noted is at birth, slightly the head size is on the larger side in the autistic males, and again between 60 to 100 months, again the head size is on the larger side, and between 6 to 11 months it can be on the lower end of normal. It's not microcephaly, it can be lower end of normal. Whereas large head, in the sense it's on the higher end of normal, it doesn't qualify for macrocephaly. If there is macrocephaly, once again there are certain differential diagnoses you need to start looking at. So that's why documenting the head size, and if it is a significantly low head size or significantly large head size, you need to start thinking of a alternative diagnosis or autism mimics. So we'll go through a few case examples to show you the importance of different aspects to pick up this autism mimics. So this is a firstborn male child, 4-year-old, presented with normal perinatal history, speech delay with poor socialization, and no history of seizures. And the examination showed its circumference of 47 centimeters and less than third centile weight. Its circumference is less than third centile. Weight and height are 15th centile. Normally, if there is a problem with the head circumference and the growth parameters are all at the third centile, then it is not of significance. But if the disproportionately head size is on the lower centile, that indicates probably there is some pathology going on in the brain. So this child had eye contact which was intermittent in nature, mild hyperactivity, and auditory agnosia was noted. There was no response to name call with a normal hearing and normal motor system examination. So this is a situation, although there are autistic features and speech delay. So the thing here is the low head circumference, which gave us a clue to say there is something going on. So what next we are going to do? We ordered a brain scan. Normal. The brain scan shows there is significant pachygyria and shallow sylvian fissure and dysplastic white matter. So this is a genetic condition associated with the structural brain malformation, and they have a higher risk of epilepsy, higher risk of recurrence in next pregnancy. The implication is the autistic features and speech delay are part of a structural brain abnormality which has an underlying strong genetic etiology. The risk of epilepsy is quite high in this child, and genetic yield is better in this child, and risk for next child with similar problem is up to 25%, which is quite high as compared to risk of a simple autism. So the handle here was accurately documenting the head circumference, charting on the growth chart, and picking up the microcephaly and then investigating appropriately. This is a second child, 5-year-old girl child, firstborn to non-consanguineous parents, had mild speech delay initially, and later on, in last 6 months prior to presentation, she had regression of speech. She was going to regular school, writing and doing everything, and then she had speech regression. The speech regression started after single seizure she had at the night time. There was no motor regression, no hearing impairment, no other major behavioral issues. There were writing issues which were noted as well. So whenever there is a significant speech regression, this is a slightly later onset speech regression as compared to what happens in autistic regression. So because of this, we did a EEG, and a wrong sleep record shows continuous discharges. The EEG was continuously studied with spike wave discharges. So throughout the sleep record, occupying more than 85% of the NREM sleep. So this you can see continuous discharges. So this is Landau-Kleffner syndrome. Around 20% have a genetic etiology. In many of them, you don't find an obvious genetic etiology. Treating with sodium valproate, high-dose benzoate at night, sodium benzodiazepine, and IV methylprednisolone and IVIG are all the part of treatment protocol for Landau-Kleffner syndrome with variable outcome. They do improve, but they may not normalize to the baseline level. So autistic regression, which we commonly see in children with autism, is almost up to the tune of 30%, but they have quite early onset. Between 12 to 24 months, they have the speech regression. Whatever the mild speech they would have occurred, they would lose that speech. Whereas the Landau-Kleffner syndrome onset is between 2 to 8 years and an average usually between 5 to 7 years of age. So epilepsy is common with Landau-Kleffner. In autistic regression, usually epilepsy history may not be there. Electrical status is diagnostic. 85% of the NRME sleep record should be containing the discharges. And in autistic regression, you will not find that. And mutations in GRIN2A is noted in around 20+% of the Landau-Kleffner syndrome, but not in autistic regression. So these are the few handles as a clinician you need to look at to differentiate between the two conditions, and should not miss out the diagnosis because the treatment and the outcomes are completely different when we pick up Landau-Kleffner syndrome. This is another case, 2-year-old boy, history of early onset epileptic spasms at 4 months. He had both motor and cognitive delay. Epilepsy, we could achieve partial control, and motor development was slowly improving, but he didn't have any eye contact, not reaching out for objects, poor fine motor activities, poor response to name call. So he had two autistic traits, that is poor eye contact, poor response to name call, but he had a lot of other comorbidities and a history in the background which was telling us it is not a simple autism, there are autistic traits only. So on the background history, at the newborn period, day 3 he had seizures, and this is the EEG MRI scan which showed bilateral medial occipital gliosis. Unfortunately, it is one of the preventable pathologies which still happens in developing countries, and it causes a lifelong devastating sequelae. All pediatricians, neonatologists, and obstetricians have a huge responsibility in reducing this burden. When we are discussing with the team from Japan and South Korea, they say, what is neonatal hypoglycemic brain injury? That is how their perinatal care has improved. So if improved perinatal care, it can be what is neonatal hypoglycemic brain injury. For us, it is not a single day without a neonatal hypoglycemic brain injury seen in the outpatients. So we have responsibility of reducing this concept, identity over a period of time. So the risk factors, as you all know, IUGR, IDM, premature babies, large for dead babies, poor feeding, perinatal asphyxias, children under phototherapy, and early discharge in a primary mother within 24 hours discharge. They have not established the feed, you discharge them. They are at also high risk for this neonatal hypoglycemic brain injury, which causes pervasive developmental delays. So that is a preventable perinatal problem presenting with autistic traits, and can be sometimes confused when there is no perinatal spasms or the spasms in the infantile period may be absent in some of them, and they just present with visual impairment and autistic traits. The case for a second born to consanguineous parents, so probably you should start raising a suspicion that there is a autosomal recessive disorder might be there. Mild motor and speech delay was there initially, but started becoming increasingly irritable and restless by 2 years, regression of speech and social interaction. So with so much of incidence of autism, today autism is, they say 1 in 100 in India, probably even more than that. We do not know, exact epidemiological data is not available, but that is far more common. But these things are rare, but it's our responsibility as clinicians to pick them up. On the background, there is history of coarsening of facial features and slow worsening of behavioral issues which were noted. And as you can see here, there is a thick nose and the lips are thick, bushy eyebrows, and cheeks are slightly broad. So these are subtle facial features which are pointing towards a coarsening of facial features. With this kind of history, you should think of, people can answer in the chat box while we are discussing. So Sanfilippo disease. So this is a condition, it's a type of mucopolysaccharidosis wherein accumulation of the storage substance in the brain causes regression, and they present as a autism mimic, one of these things. So the history and careful clinical examination once again will give rise to the clinical diagnostic information in these children, which can be easily confirmed on the enzymatic analysis and also the genetic analysis. So that's a genetic etiology, which can be a mimic. Case 5, firstborn girl child, normal perinatal period, but had cognitive much more than motor delay. Started having epilepsy at 1 year of age, no purposive hand movements and significant bruxism. I think all people dealing with autism will have this diagnosis with this history. You don't need any further information, I think. I will just show you the hand movements. So can we appreciate the video?
Yes, sir. Yes.
Yeah. So it's a non-purposive repetitive midline play. So this is very characteristic of Rett syndrome. Okay. So Rett syndrome, as we know, it's almost 1 in 10,000 girls. They have significant seizures, dystonia, regression, autonomic disturbances, and no purposeful of useful use of hands and abnormal hand movements. These are very key diagnostic features, along with acquired microcephaly is the diagnostic handle, which can present initially as autism. But any girl child with these kind of hand movements, they won't use their hand for any activity. That's the biggest handle for us in the clinical examination. So those are some of the autism mimics what we discussed. I would like to briefly touch upon how many minutes do I have, Dr. Jagdish? I have, I think, few more slides.
5 minutes you can start.
Yeah, fine. I think I'll be done in that time. There is something called run-of-the-mill autism. There are no other comorbidities significantly you are looking at as a genetic comorbidities or other structural pathologies. Whereas syndromic autism, you have the autism is one of the part of the overall syndrome. Wherein these are group of children with ASD where artistic features is one of the manifestation of underlying disorder. Holistic management is possible only when after understanding the exact etiology of this syndromic autism. Hence, a detailed evaluation at the initial presentation to differentiate syndromic versus non-syndromic autism versus ASD mimics is essential. So once again, this is a 3-year-old male child, second born to non-consanguineous couple, presented with history of delayed speech and regression of acquired speech. Had normal motor development, but had significant delayed decreased social interaction, auditory agnosia with hyperactivity. Background history, he was 3 kilos, cried immediately after birth, NICU for 1 week for respiratory distress only, no encephalopathy, no hypoglycemia or seizures. Those are the risk factors what you look for. And the head circumference was 56 centimeters, which was way higher than the 97th centile. So that is a clue for you to say this is not a simple autism. Multiple lipomas on the abdomen and back were there. That is once again a clue telling that there is something else which is going on. Stereotypic behavior such as hand flapping was noted, spinning, which can be part of autism. And swinging round and round, it's also once again stereotypic behavior of autism. But two things which stood out were the head circumference, which was significantly large. Initially, we saw low head circumference. Here it is a large head circumference with multiple lipomas. You can see these lipomas here. These were the lipomas which were there. This is another lipoma which can be seen. This is another angle which is showing the lipoma. So subcutaneous lipomas, you can have skin tags as well in this condition, and a large head and open mouth. So this is a condition which is, we have now around 3 children, not very common. So as compared to 3 children of autism every day we diagnose, in last 4 years we have 3 children with this condition called, oh sorry, I'll just go back to this one. So the EEG showed generalized spike wave discharges. CAR scoring, the IQ was 37.5, so indicating a severe autism with significant moderate intellectual delay. BERA was normal, MRI brain, sorry, it was showing mild prominent VR spaces, which can be actually seen in this condition. There was a heterozygous nonsense mutation noted in PTEN gene, which is associated with a condition called Cowden syndrome. So why do you have to diagnose this condition? Because by 18 years onwards, they have a higher risk of thyroid carcinoma. And after 30 years of age, they are at a higher risk for colon cancer. So you need to have a regular screening program. So, but they have all the features of autism. But these are the handles which will make us think, okay, it is not a run-of-the-mill autism. This is a case 7, firstborn girl child, 4 years, no perinatal problems, had cognitive more than motor delay. Walking by 2 years of age, speech, she had only single words, poor social interaction, and the CAR scoring had shown 35 score, DQ of 68. So mild intellectual delay with mild to moderate severity of autistic features were there. But what made us think of it is probably something else other than just a simple autism is this dysmorphology. So there is a very broad root of nose, inner epicanthal folds, stubby tip of nose, and a slightly long philtrum, elongated facies. All these things made us think that this child has a dysmorphology, which is contributed by a genetic underlying cause and causing autism. So this child had a 16 chromosome 6q14 deletion syndrome, which is associated with autistic features along with intellectual delay as a manifestation. Some of them can have epilepsy, significant motor delay as well. So this, once again, the clue was your clinical examination, your impression of the child. It is not just a simple autism. And tuberous sclerosis complex, most of the clinicians are aware, the hypopigmented patches and the hyperpigmented plaques, orange, all these things. It is very high risk of autism as a comorbidity in tuberous sclerosis complex. We have children where epilepsy is not a problem at all, but they have very severe autism. So that is one of the comorbidity which is very difficult to tackle in tuberous sclerosis complex. The everolimus, which is used as a disease modifying agent, is not well studied to know it is good and helpful in reducing the skin plaques, in reducing the epilepsy, but whether it can reduce the autistic traits has not been well studied so far. Last case, so it is a 2-year, 3-month-old male firstborn child. Walking started by 18 months. Many children will have a slight delay that wouldn't raise your antenna, and speech delay with impaired socialization was there, and auditory agnosia. So you were started on therapy early, by 22 months you were started on therapies. He presented to us at 3-year 9 months with recurrent falls while walking or more while running. He started walking on his toes, and during this period, when you did a clinical examination, there is evidence of proximal muscle weakness in the lower limbs, significant calf hypertrophy, and Achilles tightening. Your CPK was 15,000. So your diagnosis here is obviously Duchenne's muscular dystrophy. Okay. So this child had Duchenne's muscular dystrophy. If you go back into the history, he had all the features of autism. So where did we go wrong? We didn't go wrong, but that's how the natural history of presentation in some of these conditions. So in a study published in 2018, when they evaluated 56 children, 11 of them, almost 20% of them, had met criteria for ASD based on the PRS scores, which were they used to diagnose autism, which is quite a high incidence. In our own cohort, we have around 5-6 families where they initially had autism diagnosis. Later on, they had all the features of Duchenne's muscular dystrophy. So it is not very rare, but you need to keep a lookout even in the initial management, or especially male child. Maybe look carefully the calf examination and make sure you are not missing out on these kind of pathologies. In summary, detailed perinatal history need to be documented. Make sure there are no high risk factors at the time of birth. A family history to see if there is a high degree of consanguinity, which will increase the risk of autosomal recessive disorders. A complete anthropometry, chart it on the chart and compare whether it's the head size is large, body size, because the cerebral gigantism is another cause of autism, where all the centiles are on the 97th centile or above. And skin examination, as we saw, both the tuberous sclerosis complex and the Cowden syndrome and many other genetic syndromes. EEG should have a low threshold, especially in situations like autistic regression, and genetic evaluation as and when required. So it's a comprehensive, I think this is one condition where the whole of the medical and the paramedical team is coming together along with the scientists of the world and the policymakers, because this is going to cause so much of cost to the caretaker that it's in coming days, it is going to be one of the biggest problem we'll all have to tackle with, and we need to find a way to help these families. Thank you.
Thank you, sir. Thank you very much, Dr. Lokesh Lingappa, sir. for speaking about the differential diagnosis, that is co-autism mimics. Thank you very much for your excellent presentation in detail by using the slides as well as the videos, so that the pediatricians and the senior residents can be able to know differential diagnose as well as assess. Thank you very much, sir. Thank you for your presentation. Now I would like to introduce the next speaker, that is Dr. Ramesh Srinivasan. He is a consultant pediatric gastroenterologist, hepatologist, endoscopist, and a liver transplant pediatrician at Apollo Hospitals, Jubilee Hills, Hyderabad. He worked as a consultant gastroenterologist at Alderhead Children's Hospital, Liverpool, and was a senior lecturer at the Institute of Child Health, University of Liverpool, UK. He completed MD Pediatrics from PGDI Chandigarh, further trained on UK National Grid to complete Subspecialty Board of Certification in Pediatric Gastroenterology and Hepatology. He trained at prestigious institutions like Great Ormond Street Hospital, King's College Hospital, London, and St. James University Hospital, Leeds. And he published almost 27 international indexes, and he received awards like Silver Medal Pediatrics PGDI Chandigarh during the post-graduation, and Gold Medal for Best Outgoing Student and Surgery, and First Merit Award in Internal Medicine. We welcome Dr. Ramesh Srinivasan. Thank you very much, Dr. Ramesh, sir, for giving time. And we'll be waiting for your talk that is about autism and gut. Thank you very much. Over to Dr. Ramesh Srinivasan.
Thank you so much, Dr. Jagadish, for inviting me to be part of this webinar. It's been a pleasure to be amongst you who are all interested in autism and share my thoughts on gastrointestinal problems in autism. Dr. Srikrishna, in his particular presentation, had made a comment that gastrointestinal abnormalities as comorbidities in autism and as something which can exacerbate autistic behavioral problems are very well known to all of you. So I'll be clinically focused on what GI considerations we have in children with autistic spectrum disorder. Yeah, so all we know is from the presentation so far, we are knowing that autism is becoming very, very common. Possibly the incidence is around 1 in 100 children. Maybe it's going to increase in the time to come. So in this condition, we are basically desperately looking for a cause and a cure. So these two things are basically, they have become the holy grail now, and we are trying to chase it, both scientists as well as clinicians. Now, gastrointestinal symptoms are common in children with autistic spectrum disorder, as or possibly more common than in children without autistic spectrum disorder. Now, if we look at history, Kanna's original series of 11 patients with what he described as infantile autism, 7 of them had gastrointestinal problems. Among the comorbidities, possibly GI symptoms are very, very common in them. In different series around the world, there have been a lot of variation, sometimes as small as 9% to almost as high as 90% of patients had gastrointestinal symptoms. Most common symptoms as far as clinical practice goes is constipation, diarrhea, which basically could be constipation with overflow, gastroesophageal reflux, sometimes malabsorption, food allergies. But a very important chunk is food aversion, extreme pickiness with the food selectivity, and hypersensitivity to textures in the mouth. So these are actually the different kinds of problems faced by us. Now, among other issues are slightly increased preponderance of inflammatory bowel disease and microscopic colitis are also seen in these children. So why is the gut such an intriguing thing? We are talking about autism. There are lots of theories. It's a mysterious kind of association between the gut and the brain. And now we talk about something called a gut to behavior cycle. Now, what happened is from around the late 70s, there has been a concept called the leaky gut hypothesis and how this affects brain, mentation, affect, emotion, cognition of these patients with autistic spectrum disorder. It is hypothesized that the gut in children with autism may be leaky to food antigens, bacterial antigens, metabolites produced by bacteria like serotonin, and these may actually translocate across the bowel wall, enter the bloodstream, cross the blood-brain barrier, and affect the way the brain works. So this is kind of a long-winded but a plausible theory. This concept is not debunked as yet, and many people still regard this as a plausible explanation for what happens in children with autism. Now, important to say right at the beginning is There is no particular GI disease which is associated with children who have autistic spectrum disorder. Once again, no particular GI disease is known to be causative of the symptoms of autistic spectrum disorder. These are associations, these are comorbidities. These basically, the GI symptoms may actually exacerbate the behavioral problems which children with autistic spectrum disorder have. Now, basically, we all talk about different kinds of food allergens and food antigens. Our most research is focused on casein and gluten. And we think that they are some substances which are opioid-like, called exomorphins. Like, for example, let us say gliadomorphin from gluten, as well as casomorphin from casein, which may be the opioid-like molecules which may actually enter the blood-brain barrier, enter the brain, and affect an opioid-like kind of effect on the brain. And that may cause constipation, it may cause pain sometimes, it may actually work through serotonergic, dopaminergic, or GABAergic pathways. So we really do not know. There are a lot of things we do not know. We postulate, there are theories about, and also there have been some experiments where people have proved that some chemicals in the urine, like paracrasols, are increasingly excreted by children with the autistic spectrum disorder. And one other association is about dysbiosis and what kind of bacteria live. Do they have a different kind of bacterial microbiota living inside the intestines in autistic spectrum disorder? Long story short, increased levels of Clostridium and Sucharella, an organism, have been found in children with autistic spectrum disorder. How it translates to behavioral changes and the gut-brain axis being affected is hugely unknown at the moment. So basically, there is a hyperserotonemia, which everyone acknowledges, which happens in children with autism. And this may actually affect the brain, emotions, and attitude, and the response to stress and the kind of behavior children with autistic spectrum disorder show. So in clinical terms and practical terms, what do we see on a clinical basis in children with autistic spectrum disorder? Food selectivity, wanting same kind of food, not wanting to taste anything different, having this neophobic response happening all the time. Aversion, closing the mouth, zipping up the mouth, turning the light. Oral hypersensitivity, only takes pureed food, only takes this kind of food, doesn't allow lumpy food, can't eat bitty food, can't take anything crispy, variations and permutations of different nature. Gastroesophageal reflux, very, very important. Many of them may show lots and lots of facial features which may suggest they have silent gastroesophageal reflux. It may exacerbate their behavioral symptoms also. Allergies like eosinophilic esophagitis, constipation, #1 diagnosis. Loose motions, slight higher association with celiac disease and inflammatory bowel disease in groups of autistic spectrum disorder, where population studies to an extent have been done. Poor sleep pattern may be a manifestation of GI distress. And rumination, spitting, and pica. These are the different kinds of GI issues normally encountered in autistic spectrum disorder. So lack of communication with these children reduces the way we can actually obtain information. And many times we have to wait on non-verbal clues and picking up some verbal clues, what they give, to actually use our judgment and try to find out whether they have a GI problem associated. And altered behavior is an important thing for us clinicians to actually identify. Now, GI symptoms presenting as altered behavior. In my clinical practice, autistic spectrum disorder children may show slightly different kinds of movements. They may actually show what I typically note as a throat tapping movement. They may keep on tapping the throat. Many times, this could be an underlying gastroesophageal reflux or an eosinophilic esophagitis. Sometimes they tap on the sternum, on the chest, and that could also suggest a dysphagia or dinophagia, or basically it could be suggestive of gastroesophageal reflux disease, esophagitis. Sometimes they are actually pressing their belly on other surfaces just to get some kind of comfort, which is trying to reduce the kind of pain on the belly. They may actually sort of press their bellies on the table, on the chair, on inanimate objects, try to get some comfort by doing that. Sometimes they scream and cry with no particular reason at all. And many times we have seen that their sleep disturbances are actually a manifestation of what happens in the GI tract. And many times they may actually become very different or oppositional or defiant because they are trying to cope in a different kind of way with their emotions. So there are so many different things, like echolalia, saying what the mother would say if they have a pain in the abdomen, like saying, does your tummy hurt? They keep on repeating, does your tummy hurt? It basically means their tummy is hurting. So that is something. Sometimes what is called a grazing behavior, keeping on eating and eating and eating, sometimes on clothes or collars, etc. And so they come in different variations and combinations. Sometimes self-injurious behavior, slapping themselves on the face, on the mouth, on the cheek, or on the chest. And these are things or non-verbal clues which have to be picked up as suggestions of possible GI distress. There is no proof for us to do that, but we may want to investigate and treat them as such. Now, sleep disturbances, increased irritability, non-compliance, and oppositional behavior. All these are actually too well known as manifestations of what happens in the GI tract. Now, important thing for us to note is to pick up non-verbal clues or verbal clues if they actually can say like echolalia, etc. about their abdomen.
మీరు డెస్క్టాప్ మీద పెట్టుకున్నారు కదా అది పెట్టుకోండి.
And the GI symptoms may exacerbate autistic behavior. Recognition is vital, and basically treatment may improve quality of life of the patient and the carer. So what do we do in terms we have a GI problem with someone with autistic spectrum disorder? We treat them just like how we would treat normal children who have a GI symptom. But here you are going to pick up the non-verbal clues and try to make up in your mind whether they may have a problem of that nature or not. Abdominal x-rays may suggest fecal loading, which can go with constipation. If gastroesophageal reflux is suspected, we normally give a 4-week course of proton pump inhibitors to actually see if it makes a difference. Trying to do endoscopy, next step, and basically trying to find out if there is any esophagitis, eosinophilic esophagitis, gastroesophageal reflux, Helicobacter pylori gastritis, or a malabsorption comes next. For constipation, polyethylene glycol, PEG, what we normally use. 3350 seems to be a very good medicine for that. Obviously, doses have to be increased, try to disinfect and actually maintain them on those particular doses. Trying to do a toilet training with these children is actually very important. In case of diarrhea, first checking out that they do not have any infestation like Giardia, amoebiasis, cryptosporidium, very important. And once again, basically trying to look for celiac disease. And then small number of them may have actually lymphonodular hyperplasia, which could be suggestive of a food allergy, or they basically can have inflammatory bowel disease. Many of them have microscopic colitis, where obviously endoscopically everything would look normal, but when you actually do the biopsies, you may see microscopic colitis. And in case of chronic diarrhea, definitely to go for an upper GI endoscopy and colonoscopy. The most important thing is to think that they may have a gastroenterological problem. Now, literature has got very little to try and connect what is happening with the GI tract and autism. Most of the studies are anecdotal, they are retrospective, and they basically do not give large amount of population data. And there are basically, for those of us who are in mainstream medical treatments, parents basically are very anxious, they're desperate, they want to try out all treatments, whatever possible, to try and make their child's life better. So there are a lot of fringe practices as well, different kinds of dietary therapies, nutritional therapies, etc., which I don't think fall into mainstream research, and their claims are not corroborated by what we normally think as a mainstream medical research. So lots of blogs, forums in the internet, lots of people depend on them, and unfounded therapeutic claims are far too many in this particular area. So treatment wise, basically depending on what the cause we think, we have to treat, and we basically have to check whether it makes a difference to them. For food selectivity, it's a gradual introduction. Time is the healer, and then repeated representations of food. For food aversion, once again, try to desensitize, trying to do oral feeding exercises are important. For gastroesophageal reflux, trial of proton pump inhibitors, if necessary, upper GI endoscopy and particular treatment depending on the cause. For constipations, laxatives, excluding hypothyroidism, excluding Hirschsprung's disease. Loose motions, always exclude celiac disease, inflammatory bowel disease, and microscopic colitis. And for food allergies, obviously to treat and to test for rumination and spitting, obviously appropriate investigation and reassurance is very much essential. Now, one important thing is dietary interventions in autistic spectrum disorder. All of us will definitely have this particular issue where we may have different opinions about gluten-free, casein-free diets. This is the most popular yet scientifically unproven intervention for autistic spectrum disorder is gluten-free, casein-free diet. All of us may have different opinions on it. Now, in 1971, there was a particular trial by Goodwin and others where they reported that 7 out of 15, about half the children with autistic spectrum disorder improved in their behavior when they were put on gluten-free diet. From then, gluten-free and casein-free diets have actually caught on, and most children with autistic spectrum disorder may have been on it for a period of time or are actually continuing on it for a long period of time. Now, the important thing is randomized control trial and systematic reviews have not proven that gluten-free, casein-free diets do anything for children with autistic spectrum disorder. But many parents, even in documented studies of quality of life, report that their children's behavior has actually got better on gluten-free, casein-free diet. So the scientific data is lacking, and we are waiting for these things to appear. And parents sometimes may misinterpret variability in child's behavior as improvement, and that is something which we need to keep in mind. So European Journal of Nutrition basically have published their work on 6 randomized controlled trials and using gluten-free, casein-free diet. They have actually brought about a systematic review and found that there was little evidence for GFCF diet is beneficial to children with autistic spectrum disorder. So we wait to see in this particular area what is yet to come. So prevailing scientific evidence does not support elimination diets for autistic spectrum disorder children. Sometimes children with autistic spectrum disorder, more because of the food selectivity and the picky nature of the eating, may have problems with vitamin deficiencies. Some of them may have calcium deficiency. Many people actually supplement them with calcium, omega-3 fatty acids, iron and multivitamins, depending on the requirement. So in conclusion, there is no one particular GI disease which is a hallmark disease in children with autistic spectrum disorder. GI symptoms do not actually cause autism. Similarly, autism and GI diseases may be comorbidities. One may not actually cause each other. We really do not know a lot about how the gut influences what happens in the brain, cognition, affect, behavior, etc. Autistic children may have an altered behavior or exacerbation of their behavioral difficulties when they have an underlying GI problem. And we as clinicians need to pick up verbal, but more importantly, the non-verbal clues and think and treat and investigate as necessary. So elimination diets do not have a strong evidence for us to use, but obviously the parental kind of perspective may be different in this particular scenario. And there is no clear proof that GI disturbance cause or exacerbate autistic spectrum disorder symptoms. So importantly, we need to remember the conditions which can happen, pick up on the non-verbal clues and treat. Thank you so much for having me here.
Thank you, sir. Thank you very much, Dr. Ramesh Srinivasan, for your excellent presentation on the, that is very important, gut and autism. Because most of the pediatricians or clinicians and physicians, they will be getting confusion with regarding the diet. Thank you very much. You have revealed everything. Thank you, sir, for your presentation. Thank you.
You're welcome.
Now, I would like to introduce Dr. Meenakshi Chintapalli, madam. She will be talking about what is new in autism spectrum disorder. And she's from GMC, immigrated in the United States, that is in 1976 year. And she did the ambulatory fellowship from University of Michigan, practiced in San Antonio for the last 33 years. She's a community leader, professional, community educator on 0 to 3 years, child trauma and neurodevelopment and positive parenting skills. She's a member of many medical societies and American Academy of Pediatrics Council member for COEC, COCAN, COSH. And she won many medical awards, including AMA, that is Professional Excellence in Leadership, on WHO's WHO International, Americas, and Marcus. She wrote 3 books on protecting the hard wiring of infants' brains, positive parenting, and trauma, focused on cognitive behavioral management. Thank you very much, ma'am, for your presentation. I welcome Dr. Meena Chintapalli from US. Over to Dr. Meena.
I thank Dr. Jagadish and IAP for giving me this opportunity to talk about what is new in ASD, and I was very enthused. I'm so sorry about the inconvenience. It's a neurobiological disorder, and it is early disorganization in the neuroplasticity that has started prenatally and has occurred in the first few years of life. And the nomenclature has now brought everything under one umbrella, ASD. And the prevalence is very high at 1.8 to 2% and getting worse. That is one of the reasons there is a pressure to diagnose early, start therapy early, ideally under 12 months, to work with the early network formation, which is a lifetime network, to prevent progression of the neurodevelopmental disorders. That is one of the reasons the screening in the MCHAT has been shifted down to 15 to 16 months, not at the universal screening at 18 to 24 months from the AAP. ASQ-SE screening is recommended from birth onwards in the first 3 years. A definitive diagnosis of ASD is not important for getting enrolled into an ECI or PPCD through the school system. We know we have a broader knowledge about how epigenetics work. The primordial stem cells as well as the genetic factors either get expressed or do not get expressed based upon the environment, the nature, the support systems, and the experiences promoting or demoting the genetic expression, good and bad genes. For instance, in the red genes, if there is an environmental adverse factors like ACE factors, toxic stress, chemical exposures, infections, domestic violence, anything that is stress induced where there could be an expression by transcription onto the genes without disturbing the DNA sequence of the major genes. Intrauterine disturbances have already started for the neurodevelopmental disorganization that persist postpartum also, and their pruning is inefficient, ineffective, confused networks leading to the manifestation of neurodevelopmental disorders. Whereas when you have a good controlled environment where there is nurture, protection, support systems, intrauterine expression of the neurodevelopmental genetic predisposition does not get expressed, and that continues into the postpartum organization, axon proliferation, neuroplasticity, and protection. This is the same factors I'm talking about. The purple represents the cells that are regulators prenatally. Green represents postnatally, and this is the work of Eric Kirchesney, and that determines, translates, gives signals for neuroproliferation, migration, differentiation, synaptic proliferation, and organization. This is also a visual representation of the same factors I'm talking about. Epigenetics have a major role. As far as the diagnostic criteria are concerned, we have divided that into two major domains. One is related to the social, emotional, learning capacity in communication and pervasively present in multiple contexts, and interaction deficits in verbal and nonverbal communication skills. Second domain is the restrictive repetitive behavioral disorder with behaviors as well as activities and circumstances. The three categories in domain A have to be present to diagnose ASD, which is social emotional reciprocity, nonverbal communicative behaviors and social interaction, and developing and maintaining relationships and school social adjustment. And description has been given earlier. I'm not going to spend time on that. The second category is 2 out of the 4 subfactors have to be present, which is stereotyped repetitive motor movements, rituals, poor transition because of this rigidity, inflexible attitude of verbal as well as nonverbal behaviors, highly restricted and fixated interest. Sometimes it is good, like math savants and as well as excellent artists. Some of them are really artists, it's good. But this does interfere with the day-to-day function because they're so rigid with their fixated notions. Hyper or hyperreactivity to sensory input or unusual interest in sensory aspect of an environment. An example is being repulsive to certain garments, eating the same food, not able to tolerate even the mild noises, and hyperacusis, being very disturbed with the lights and so on. There is another category that is added as an independent inclusion in ASD recently, that is social pragmatic communication disorder, where there is a language problem but no repetitive behavior to classify for autism. The severity is based upon the level of support a child needs to maintain the autonomy. Level 1, 2, and 3 could be respectively mild, moderate, and severe. In level 1 and 2, there is substantial, some minimal to substantial support where an autonomy of a child can be promoted while working with his or her weaknesses in organization planning and social emotional learning and repetitive restrictive behaviors, whereas level 3 falls into the category of complete dependency and there is no autonomy for these individuals. That's a severe category. And every newborn is born to learn, and they learn the best in the quiet alert state, which if there are 6 states that we know of, that is the best state. And if every newborn is born with 100 billion cells that connect and form pathways for the first time, lifetime, why is there so much of neurodevelopmental disorder and disorganization? Is autism spectrum disorder an expression of failure to repair the attachment disorder? And mentalization, which is a new terminology by the psychologists, where a child measures the external stimulus and experiences, tries to internalize and identify and make a state of being, either to thrive or survive. If everything is with a positive reciprocity with the primary caretaker, relational bonding, self-trust, worth, and care, that is thriving from the external stimuli as an experience internally. Whereas when an infant just survives, going into freezing dissociation of survival with the fight and fright, that leads to multisensory segregation, and they cannot have motivational learning. And that may be causing disturbances, and that is the modern thinking. Here are the networks, 100 billions every child is born with, even 80 billion does exist in syndromes, as well as in drug and alcohol babies, as well as in NICU graduates. Based upon the experience in an extrauterine environment, there is a smooth connection when there is a nurture and care and love and reciprocity with the primary caretaker to make smooth connections from midbrain, eating, pooping, and sleeping, to the belongingness, to a social brain connection that completes its connection within 12 months of the child's primary setting of the wiring, which is a lifetime wiring. Something that disturbs the child's state of mind, even as early as 1 to 3 months, maternal depression or adverse factors, ACE or toxic stress, can cause multisensory segregation that fails in a hierarchical fashion to go to the neocortex, where thereby learning disabilities can happen.
Madam, your time is yeah.
So I'm sorry,
fast.
because
Maximum 5 minutes. Thank you.
I have to complete this because I was fiddling around with the other one. So in the brain volumes of the autism spectrum children are excessive glia, excessive synapses, mini columns. These persist until the first, including big amygdala. These persist in the first 48 months of life, and they start because disuse atrophy later on. That leads to much more difficulties, and the disorganization in the neurodevelopmental organization of the primary wiring is responsible for these huge brain volumes. These are studied through MRIs, for the neuroimaging studies. I'm not going to enumerate. The latest research shows early network disruption is etiological pathogenetic of autism spectrum disorder. DTI fMRI denotes the structural brain connectivity. Flow anisotropy decides the functional as well as structural integrity of the systems. Voxel-based DTI fMRI measures the white matter connectivity. And in the ASD, there is widespread decreased connectivity. In ADHD, there is increased and decreased based upon the structures that are involved. Whereas in OCD, increased flow anisotropy is sustained because it's a late onset disorder. Looking at the structures, cortical structures, now I don't have time to go through. There is a disturbance in the intercortical hemispheric connection through corpus callosum of genu and splenium, corticospinal, occipitoparietal, frontoparietal. Many of these pathways are involved that show brain injury early on, and myelin formation, poor myelin formation, because there is low mean diffusivity as well as flow anisometry that denotes an early network injury. And when the fusiform cortex is not connected to the amygdala, there is no awareness of an emotion and a face, and there is apathy. But when oxytocin is given into the nose, these in the pathways reconnect with the fusiform to amygdala as well as accumbens, striatum, and temporal cortex. This improved the recognition in social pictures. Whereas ASD children usually read out of the inferior temporal cortex. That's why they would rather look at a computer than the mother. For them, a table and a human face is the same. So there are many cognitive deficiencies because the connectivity is disturbed in all these intercortical hemispheres to temporal, parietal, singular, occipital, everything. This is a representation of the same. And I will go into this one, which is much bigger, so you can see it. The hierarchical distribution, network formation to the frontal lobe, neocortex is disturbed by any factors that can cause multisensory segregation, that caused quantitative deficiency of dopamine, serotonin, and other neurohumoral chemicals that can lead to many learning disorders and disorders that we see. This is from Stephanie Amy's study, latest one. She compared OCD with the ASD. There is some screen that is being blocked here. I cannot control it. Those pathways look like this in the ASD. And it is the same thing in ADHD. The OCD maintains the frontal lobe connections. The OCD maintains the frontal lobe connections, but not in OCD, but not in ADHD. Talking about electronics, electronics has the same effect. 3 hours in disengaging electronics per week can cause cortical as well as gray matter and white matter attrition. It is actually burning the cerebral cortex. That leads to 14 neuropsychiatric conditions. That includes bipolar depression as well as ADHD and ASD symptoms. Coming to the nerve chemicals, if you give me a few more minutes, glutamine, glutamates and GABA are very, very important for neuroplasticity, differentiation, and apoptosis. And NMDAR is a glutamate, and agonist for NMDAR, D-cyclosporin, overcame some of the repetitive behaviors as well as social withdrawal. Antagonistic to the NMDAR, momentin, increased control the symptoms of ADHD, agitation, and irritability. Serotonin is very important for neuroplasticity, mood and regulation, sleep and memory. And we have to use sometimes to control the excessive SSRIs, fluoxetine, to control some of the serotonin surges and the behaviors as a result of the serotonin. And serotonin is very exclusively low in younger age groups, high among the ASD older age groups, and this is exclusive for ASD. Dopamine that is secreted from the mesocortical limbic pathways from prefrontal nucleus accumbens is good for cognition, everything, and it causes, and D3 and D4 blocking agents, aripiprazole and risperidone, have helped control the irritability and mood instability, whereas D1 agonists have increased the social response. Therefore, dopamine surges need to be studied still. Acetylcholine is a very important neurotransmitter and is very important protector of the brain cell injury against the maternal-induced IL-6 or immune factors. It is important for sensory processing, attention, and memory. And choline administered to the ASD patients, galantamine and donepezil, has helped the individuals.
Ma'am, excuse me, sorry to interrupt you, ma'am. Its time is up.
Give me 2 minutes. Give me
Yeah.
2 minutes.
Okay, right.
Because we've fiddled around with the other one.
Yeah.
Arginine, vasopressin, and oxytocin are very, very important. Oxytocin seems to be very important from the relaxation responses. Nasal insufflation of oxytocin has helped control the irritability, self-inflicting injuries, and socialization in ASD patients. It is also important for neuromodulation and identity of the self with the world. Melatonin has more properties than sleep-wake cycles and controlling the sleep latency. It is a protective it protects the brain against inflammatory factors, and it helps cognitive skills also besides the neuroplasticity. Vitamin D, which is not looked at, is an important steroid that has been a cofactor, excellent antioxidant, cofactor for dopamine, GABA, serotonin, and glutamate. It protects against the brain inflammation and very essential for neurotrophic factors and neuroplasticity. Orexin levels high can control serotonin and melatonin suppresses it, but oxytocin helps overcome that one. This hormone in the right amount secreted in hypothalamus is important for regulating stress, cognition, sleep, appetite, excitement, and metabolism. I want to talk about endogenous opioids, enkephalins, endorphins, and dynorphins very high in ASD, along with very big amygdala. These are usually secreted when the brain feels injury, trauma, emotional trauma, or physical trauma, and they secrete endogenous steroids in freezing dissociation and in a flight of mood. And that is one of the reasons ASD have pain insensitivity, poor socialization, increased stereotype movements. Those were overcome with the naltrexone. In summary, the conclusion is that everybody should be very cognizant about the 0 to 3 universal nurture curriculum that can protect the brain with the hard wiring, lifetime wiring, and not cause multisensory segregation, but cause multisensory integration and this can only happen through community-wide parenting education and the community-wide education and looking at the stressing factors that may be interfering with the early primary network formation. That is where we have to catch all these neurodevelopmental disorders to prevent them from causing long-term morbidity, hemorrhage, and funds in the system. I thank you, Dr. Jagadish and IAP, for giving me this opportunity.
Thank you very much, ma'am, for your presentation about what is new in autism spectrum disorder. Now, the next topic will be by Dr. Jeeson C Unni, sir. He will be talking about, do medications work for autism spectrum disorder? And about Dr. Jeeson C Unni, sir, he is a editor-in-chief, Indian Academy of Pediatrics Drug Formulary, and is a senior consultant, Aster Medcity, Kochi, Kerala, and is a national convener, Indian Academy of Pediatrics Poor Scholastic Performance Program for the year 2007 and 2011. He is actively involved in Indian Academy of Pediatrics IAP advocacy for children with learning disabilities, and is a past secretary and president of IAP Kerala State Branch, and is a past secretary and president of NNF Kerala State Branch, and is a past secretary and chairperson of IAP CMIC, and IMM past chairperson IAP Neuro Developmental Chapter. And he is a AC VIP member for the academic year 2016 and resource person and master trainer for various IAP action plans. And he authorized a book called Life Skills, and he contributed many chapters to various pediatric textbooks, published 80 odd articles, and he is editor-in-chief, Child India, and is a scientific chairperson of Pediatric Portfolio. Thank you very much, sir, for accepting. Thank you, Dr. Jeeson, sir. Over to Dr. Jeeson C Unni, sir. Thank you very much. Please go ahead with your presentation.
Okay, so thank you, Jagdish, for inviting me to talk on this topic.
Thank you, sir.
Now, the question is, does medicines work for autism? And we know that there is, as many speakers have said so far, that there is no efficacious medical treatment for the core symptoms of autism. And most of the uh, treatments are for the comorbid conditions, if at all. And the American Academy of Pediatrics and the Academy of Pediatrics suggests that we target one or maximum two of the problem behaviors that is affecting a particular child for considering medications. So medications have a very small role. It's mainly other treatments that are required. Medications are used very carefully in children with autism. Now, the difficulties with studies on pharmacotherapy of autism is that because autism is such an extraordinarily heterogeneous disorder, the manifestation is influenced by many variables and like language level, age, cognitive ability. So it's very difficult to capture the treatment effect of a particular drug that you're giving. Similarly, for interventions, it's very difficult to say which intervention works, which intervention doesn't, because there's no gold standard for the measurement of change in autism symptoms in clinical trials. Recently, there was an article by Dr. Shefali Gulati that cars could be used, but that has to be validated. But so we're looking forward to the advent of biomarkers for autism. For instance, you have biomarkers for tuberous sclerosis and Fragile X, which could be used for measuring the effect of treatment. So what are the medications that may be effective? So the only drug that has really got some evidence is risperidone and maybe as aripiprazole. Now these have been studied. So when you're assessing a drug for autism, it is the studies are done on a particular aspect of autism. Like for instance, here with the atypical antipsychotics, the studies are done on social withdrawal and stereotypic behaviors, not on any other. It doesn't affect the core symptom of autism. So it is for some area of autism that is problematic for that particular child. That is where you use these drugs. Whereas aggression, there is very severe self-harm, and when you need to de-stress a person, maybe a child who's really affected by that, you might use risperidone or aripiprazole. Now, the in autistic children, therefore, when you use risperidone, the studies have shown that the irritability subscale of aberrant behavior checklist is much improved on treatment. Stereotypy is better, and aggression in autistic children is better in these children who are treated with risperidone. Now, when you're using risperidone, you use all drugs in any differently able child. You start with a small dose. Before you start, you must discuss with the parents. You must discuss with the goals of the therapy and how long you're going to treat and how you're going to taper. What are the side effects you're going to expect? So these are things in education is very important before you start any long-term drug for any child, differently able child. And the autistic child or the differently able child should also be there in because they understand a lot of things. Though you feel that the child with the autism spectrum disorder is not understanding what you're saying, despite him being very inactive in his own world, he understands a lot of things. And therefore, the explanation should be done in the presence of the child and the parents. You start at a very small dose and gradually increase, and this reduces the side effects also. And you have to periodically see when these drugs can be stopped. Now, the clinical trial designed to evaluate the safety and efficacy of very small doses have found very disappointing results. So you need to find a dose that is effective for that particular child. The side effects of risperidone are severe somnolence and daytime drowsiness, and this affects other treatment modalities interventions that you want to do for ASD. The metabolic adverse effects of weight gain, dyslipidemia are common. Excessive drooling could happen, and extrapyramidal symptoms also to be expected. So you must know every drug that you're using for these different able children, study them very well, and know the complications and side effects and how to monitor them. Aripiprazole is also used for short-term intervention for behavioral aspects of ASD in children and adolescents. It reduces irritability, hyperactivity, and diffuse stereotypies like repetitive behavior and purposeless action is also reduced. And the notable side effects again are the same as with risperidone. And some children do better with aripiprazole than with risperidone, and some it depends on the drug that you are more comfortable with. Both these drugs are evidence-based for treatment of stereotypy and aggressive behaviors and repetitive behaviors in ASD. What about antidepressants in ASD? Now, most of the studies have focused on when you're using an antidepressant like SSRIs, it is mainly primarily for repetitive behavior, and that is what is focused on in all the studies. And you find that there is some improvement in the repetitive behaviors in adults with fluoxetine. Fluoxetine also, there is some reduction of repetitive thoughts and actions in small group of adults with autism. Now, the systematic reviews have report that SSRIs have no effect in children and limited positive effect in adults. So be very careful when using SSRIs for repetitive behavior. And SSRIs also could induce activation and agitation in this population. Therefore, that must be factored. And therefore, you must be very careful while using these drugs in children with ASD. What about ADHD and ASD? Initially, when the studies were done with methylphenidate as the dose that we use primarily for ADHD, we found that there was a lot of negative side effects. Irritability, self-injury, and stereotypy increased. And there were a lot of complications. A lot of side effects were very severe, and they stopped giving methylphenidate for these children. But later, RCTs by the Pediatric Psychopharmacology Autism Network found that when you reduce the dose, almost half the dose of methylphenidate that you use for ADHD without ASD, you found that there was about 50% effect. The effect was much less than with when you use methylphenidate for isolated ADHD, where you get a response of about 80%. With ASD associated with ADHD associated with ASD, you get only 50% response. You need to give half the dose to reduce the side effects, and you would find out the highest tolerated dose and continue that for some time. See, because therapy would, if a child has got ADHD, the therapy, all interventions would be affected. So you need to treat that, and therefore ADHD could be treated with. The second is the effects of giving methylphenidate was also found that it improved the initiation of joint attention, and there was better self-regulation and more regulated affective state in these children who are given small doses of methylphenidate. So therefore, some more research is required to confirm this, but it is something that needs to be studied. Atomoxetine, there are very few studies with ADHD in ASD. It's only for high functioning autism, and they found that there was some improvement in these children with high functioning autism, but other studies have found no improvement. So basically you use mainly methylphenidate. The studies have shown that evidence base is for methylphenidate and small doses for controlling the ADHD, that is, if it is really problematic in a child with ASD. These are other drugs which have already been mentioned. I think oxytocin nasal spray, like the doctor was mentioning, could be used for aberrant social behavior. For repetitive behaviors, we have already mentioned fluoxetine, fluoxamine. Cognition, memantine, and rivastigmine have shown promising results for cognitive improvement. And melatonin and mirtazapine are the ones that are used for sleep. Now, these are all, most of them are in investigation stage, and therefore we won't be discussing too much. What about sleep disorders? As we already mentioned over the year, everyone's worried about sleep because 50 to 80% of these ASDs children have sleep disorders, and they're found to be prominent parent-reported concern. This occurs probably, it may be related to epilepsy, it may be related to gastroesophageal reflux, it may be related to poor sleep hygiene, to behavioral insomnia of childhood, so a lot of other conditions may be causing sleep disturbances, and sleep disturbance will affect the daytime behavior of a child with ASD. Therefore, it's very important to deal with sleep problems, and it's exacerbated by the communication challenges unique to autism. So the difficulty, the transition from sleep to waking and wake to sleep, understanding the parent expectations regarding sleep. So there are a lot of issues that we need to deal with when you deal with sleep disorders in ASD. And melatonin is one of the drugs which has been used, and what short-term studies have shown that 1 to 3 months of this may be used. What it does is it significantly reduces the sleep latency time by about 20 to 30 minutes. That is it. Because they have difficulty initiating sleep, and by giving melatonin, you're reducing the latency to sleep by about 20 to 30 minutes. And that's all it does. It's not a wonder drug, but it does it is useful for short term in some children. The long term effects of melatonin also have been studied, but there are very few studies on that. And you use these drugs as short term treatment for sleep disturbances, and not for a long term. And its side effects are very uncommon and mild in nature. Mirtazapine has also been used, and it significantly reduces aggression, self-injury, and irritability scores, along with reducing the improving insomnia in these children. Now, most of these drugs are used for these sleep disorders, are used for most differently able children with sleep problems, except with sclerosis. What is that? Now, there are studies which have shown that most of these children come with 8 or 9 drugs. There's a list of drugs. There's epilepsy drugs, sleep drugs, there are drugs for ADHD, the SSRI. So you need to be able to reduce these drugs as much as possible. And sleep disorders, you have 25 medication recorders taken for sleep, and some children taking more than 1 medication for sleep. And this is something that is challenging. When you see these prescriptions, and these parents are really distraught, going from person to person. Sleep medications, finally, what we would recommend, the IEP recommends, is that sleep medications are not successfully treating sleep disturbance. And sleep medications, even if successfully treating sleep disturbance, they're not favorably affecting daytime behaviors and quality of life. So therefore, these drugs have to be used selectively and must be used for short term. What about depression and autism? We have talked about depression in the various talks that have happened today. It's very difficult to diagnose depression and autism, and we go from psychiatrist to psychiatrist, and some of them diagnose, some of them don't. And because it's very difficult to diagnose, because anyway there is communication deficits. There's a typical presentation of ASD might look like depression, and there's lack of standardized diagnostic tools. So what happens is that if there is a change in behavior, sudden change in behavior, sudden absence of screaming, a lot of agitation, sudden increase in agitation, or this lack of response to therapy that has been effective still, then you must consider depression. And the use of there are a lot of studies which show that 30,565 children with ASD, when they followed up, 64% were prescribed more than 1 psychotropic medication, 35 were prescribed 2 or more, and 15 were having 3 or more classes. So that's the difficulty of medication in ASD. A lot of drugs that are being given. More common. The excessive medications is more common in adults and children with high functioning ASD, because depression probably is diagnosed better in these age groups and these target areas. SSRIs are being used for guided by evidence in typically developing individuals, and no studies exist to determine the efficacy of SSRIs in treating comorbid depression in youth and adults in ASD. That is something that we must understand. There are not enough studies to say whether this is evidence-based. Cochrane review of use of antidepressants and recommend use of SSRIs for depression on a case-to-case basis. So you have to be very careful while using these drugs, because it's more effective would be cognitive behavior therapy, and the problems with ASD, behavioral activation, irritability, akathisia, and sleep disturbances are some things that you must factor when you use these drugs for depression in ASD. So the behavioral therapy is much more effective. CBT designed for typically developing youth and subsequently adapted for ASD is what is recommended. So cognitive restructuring and stress reduction techniques are what we need to emphasize. What about epilepsy? Epilepsy, again, very difficult to diagnose in a child with autism spectrum disorder. The subtle symptoms of seizures are very difficult to differentiate from the abnormal behaviors associated with ASD, like the staring spells, the motor tics, the stereotyping movements. So probably it is very difficult, and EEGs may be normal in some children with autism spectrum disorder, may not be actually a seizure. So you need to do an extended overnight EEG, and a good specialist who is very good at diagnosing EEG findings in ASD must be consulted for before diagnosing a seizure. And the seizures itself are the electrical discharges of the LKS syndrome and continuous spike wave activity during slow wave sleep is already shown by Dr. Lingappa, where the child may have symptoms of ASD but do not have ASD, must be diagnosed by a good pediatric neurologist. So you need a good team to diagnose this epilepsy in ASD. The only thing, the message that IAP wanted to mention is that the 4 AEDs that are effective for cognitive disorders in ASD are the newer drugs like valproate. Divalproate and is useful as a mood stabilizer along with lamotrigine and oxcarbazepine. These are drugs which are used as mood stabilizers in ASD, and not valproate. Is divalproate is useful. So valproate, lamotrigine, levetiracetam, and ethosuximide are the 4 drugs that are used for seizure control. The least detrimental effect on mood is valproate and lamotrigine. Actually, it's good. They're good mood stabilizers. Actually, it's divalproate that is effective. Lamotrigine has the least adverse effects in children with ASD. But avoid older anti-epileptic drugs. That is the message. You avoid phenobarbital, phenytoin, and primidone because there's a high incidence of cognitive and neurological adverse effects with these drugs. So this is something that we must understand. GI problems have been mentioned in detail by our gastroenterologist colleague, and they are treated because all this pain of constipation, gastroesophageal reflux, bowel inflammation, all these can aggravate symptoms and sleep disturbances in children with ASD, and they are treated as for normal children, as you treat for normal children. So that has to be treated adequately. I will stop here now to conclude that there are no efficacious medical treatments for the core symptoms of autism. Be very careful when you use medications in children with autism spectrum disorder. Each comorbid condition requires evaluation by an appropriate specialist. So a multidisciplinary team must be working on these children, and with the pediatrician and the development pediatrician following up to see if the goals are achieved. Target the main 1 or 2 problems of behaviors when considering medications, and use only drugs with sufficient evidence for targeted comorbid behavior. When you have a child coming with 8 or 9 prescriptions, don't immediately say this is all humbug, because the parents are going from pillar to post. They find some improvement. If there is improvement, don't suddenly stop drugs. Very, very gradually, after explaining why you're stopping each drug. That has to be done very carefully with good rapport with the parents, telling them why you're stopping these drugs, and use as much as possible over time. Start always with a small dose, gradually increase, keeping in mind that other symptoms might get aggravated, and try to taper and stop these drugs as soon as possible. Thank you very much.
Thank you, sir. Thank you very much for your presentation on medications. 2 medications work for children with autism. Thank you, sir. Thank you for your time, Dr. Jeeson, sir. Now, I would like to introduce the next speaker here today. He is Dr. Srinivas B. Gokarakonda. He is Assistant Professor, Department of Child and Adolescent Psychiatry, University of Arkansas for Medical Sciences, Little Rock, United States of America. And he's a board certified psychiatrist from the American Board of Psychiatry and Neurology. He also is a member of American Psychiatric Association, American Academy of Child and Adolescent Psychiatry, and American Academy of Addiction Psychiatry. And he earned his medical degree from Rangaraya Medical College. He received a master's in public health from Western Kentucky University, majoring in health education. He is currently an assistant professor of psychiatry at the Little Rock, that is the University of Arkansas for Medical Sciences. His prior experience including Bill and Melinda Gates HIV Prevention Project in India, Kelly Autism Program at WKU, and at the Center of Addiction Research, Department of Psychiatry at UAMS, His research interests include ADHD, autism, and substance abuse in adolescents. I would like to call upon Dr. Srinivas. Over to Dr. Srinivas. Thank you very much.
Thank you for the nice introduction, Dr. Jagadish. First of all, I want to thank Dr. Jagadish for his persistence in getting me on board to speak now at 3:30 a.m. So he convinced me to speak. So I'm happy to do that. And also, I want to thank IAP for giving me this opportunity to talk to you guys. And it's amazing how all these participants stayed for 3 hours without a break, and this would never happen here. We always have breaks every hour, and it's amazing how you guys stayed all through these presentations so far. So I don't want to bore with the same presentations that were already talked. So we just, if you guys have some time, we can do an activity first, and then going to my topic. Basically, my topic covers, it's a summary of all those topics that were talked about so far. So I'm going to just share the screen initially, and I sent a link in the chat box. If you guys open that polleverywhere.com, you just copy that link and paste on a browser, and you can open that, and we'll be sharing the screen in a minute. So these are the topics that we've discussed so far. We talked about comorbid conditions, diagnostic criteria of autism. We talked about the IAP guidelines for autism, epigenetics, a lot of medications that were discussed by Dr. Unni, and also Dr. Chintapalli has discussed a lot of medications that were used in autism. So I just want to ask you some questions that you guys can put in the chat box. If you open this polleverywhere.com and then use this, you can answer those questions here, and you all can see that. Okay, I'm going to clear all this. Okay, so since we've discussed about the diagnostic criteria of autism, what are the 3 domains of autism? You guys can type those in these chat boxes, not in chat box, the poll everywhere. Are you guys able to access that?
Yes, Dr. Srinivas, the time is less, 10 minutes.
Yeah, I understand that. I mean, I don't want to put the same topics. I understand that. Can anyone? Okay. Communication deficits, repetitive behaviors, poor social interactions. These are the common, domains that, we see deficits. So a lot of people are answering communication deficits, social and repetitive behaviors, restricted behaviors. Okay, good. So we have that. So, and then the next question would be, what are the common medications that were discussed earlier? Okay, I think people are still answering that. Okay. Good. Okay, so the next question would be we have risperidone, aripiprazole, okay. Good. Thank you for those responses. I think since we have melatonin was also discussed here, SSRIs. So good. So we have a lot of responses. I think people are still active in their listening. So we'll just go ahead and start my topic here. Okay, I'm just going to close this poll everywhere for a minute. And if we have time, if Dr. Jagadish allows us, we can do this activity at the end. Okay, so this is my topic. So global perspectives, challenges in treatment and management of autism. So I have no disclosures. Start with autism spectrum disorder diagnosis. You already know that it's abnormal function of three areas: social interactions, communications, and restricted and repetitive behaviors. We've discussed this before. And the criteria for autism, the diagnostic criteria for autism, this was already discussed. And this is the prevalence of autism or epidemiology of autism. We've heard that there's 1 in 54 in some countries and 1 in 100 in some countries, and you can see the differences globally. If you look at the United States and Canada, you see more than 0.8% in population, and then you have more prevalence in some countries. Australia also has a higher prevalence compared with other countries. And if you can see India and Middle Eastern countries, China, we see a lesser less diagnosis or less percentage of diagnosis of autism. It could be because the screenings, how much screening we do in a daily practice, especially in the primary care practice, how much screenings we do. So that's why it doesn't mean that we don't have cases of autism. It's the diagnosis. We are not able to diagnose as many kids. And again, early diagnosis and early intervention are the keys in treatment for autism. Here, American Academy of Pediatrics recommends an initial evaluation at 9 months, 18 months, and at the 24 months and 36 months to make sure that the child doesn't have autism and other things are ruled out. So like I said, this graph shows on the left, you see the prevalence of autism in males versus prevalence of autism in females on the x-axis and y-axis here. And this is data from 2016. Our data is not updated from our world in data. So it shows multiple countries with, the prevalence of autism here. And still here, India is in the lowest spot here compared with other countries in the diagnosis of autism. So since a lot of other presentations or speakers spoke about the diagnosis, treatment, I'm not going to discuss all that, but this is an interesting case of autism that we've recently seen in the clinic, and also I was a part of the treatment team that took care of this patient. It's a very complex patient with multiple diagnoses, comorbid conditions. So I'm going to discuss this now. So A is a 16-year-old male with a past medical history of autism spectrum disorder and chronic constipation who presented to the emergency room due to escalating agitation and self-harm behaviors. He will hit himself on his head and face to the point that he was just like, was in a boxing match, came with the black eye, both the black eyes and a lot of concussions in his head, was admitted to the hospital, and he also has a lot of bruises on his feet and knees. And also he was wearing a helmet when he came to us. So history of present illness, this patient, according to the parents, he was fine until 6 months ago, and then this aggression started all of a sudden after an ear infection. And this kid is nonverbal, and he could not express what's going on. So ear infection was treated. He still has the self-harm behaviors continued even after treating the infection. So once we admitted him, we did a CT, which was normal. We were concerned about his concussions or if there is any bleeding. Luckily, he doesn't have any of those. And parents complained about decreased appetite and chronic constipation. Like, Dr. Srinivasan said, GI problems are one of the biggest concerns because kids can have behavioral dysregulation just because of that. Chronic constipation can cause that. And he doesn't have any dental problems according to the parents. So when he came in, he was only on clonidine that was maintained for almost 7 years. He was on clonidine for 7 years for sleep and behavioral problems. And he was recently started on Prozac. Like Dr. Unni said, Prozac or any SSRI can cause activation. It could be Prozac activation that led to this aggression, but as soon as he started having these aggressive episodes, parents stopped Prozac, but the aggression still continued. So this kid enjoys school, enjoys rides, he sleeps well with the clonidine, and he was attending a developmental school. Okay, his past psychiatric history include a diagnosis of autism spectrum disorder when he was 3.5 years old, history of ADHD, a history of anxiety. Again, these are the comorbid conditions we have already discussed, and also some obsessive compulsive symptoms. So the past medications include risperidone, aripiprazole. He was also prescribed Adderall, Focalin, methylphenidate, and Prozac, right? So these are the medications that he was prescribed, and he has a history of self-harm behaviors in the past. And this is his first hospitalization. It's very surprising that this kid has never had any hospitalizations before. This was his first hospitalization. And he was previously seen in our outpatient clinic. On labs, he had elevated LDH, elevated C-reactive protein, creatine kinase is elevated, and also has elevation of ferritin levels, and his BMP was normal, thyroid were normal. So since he had so much of aggression, and parents were like, we want to know what's going on, we want to have the answers for what's going on. So there were so many labs that were done on this patient. We did the long chain fatty acids, heavy metal screens like copper, lead, all those heavy metals. We also did uric acid, and lumbar puncture was done, including infectious and autoimmune encephalopathy panels. And we also did a genetic panel that is still pending to rule out other conditions like Fragile X, and then all the genetic syndromes Dr. Lingappa has discussed. So we were waiting on those panels. And as I mentioned, CT head was done, it was normal. MRI spine with and without contrast was in, which was normal, because the parents were like, we want to know the answer. So we were thinking that he may have back pain, he may have, constipation. So we did x-rays to see if he has chronic constipation. Echo was done, EEG was done, and EKG, except the only abnormality on EKG was the QTC prolongation, because he was on risperidone. He received multiple doses of Haldol, so that's why his QTC was prolonged. So a dental consult was placed because parents wanted to make sure that he doesn't have any dental caries. Ophthalmology was consulted, and then again, in neurology was consulted, gastroenterology for again constipation. So all these specialists were consulted, and then nothing was found except for chronic constipation. So the first admission lasted for 7 days, and then he was discharged home with quetiapine, which is Seroquel, and clonidine. And he was also given Ativan for aggression and concerns of muscle spasms. As soon as we discharged him, the patient returned to the emergency room right after 1 day. And then he was sent home from the emergency room. And then he presented to another hospital nearby the same day, because he still continued to have these aggressions. And then he came to us again to the emergency room. So he was readmitted. So within a span of 3 days, he went to 3 emergency rooms, admitted again. So this time the admission number 2 lasted for 15 days. So during that admission, we did taper the clonidine, we increased the quetiapine. He was also started on valproic acid, because we were concerned that he may have head injury, and he was having this like a traumatic brain injury leading to impulsive aggression. So we started him on valproic acid. It initially helped him, but it was not helping as much. So due to that reason, it was discontinued, and trilateral or oxycarbamazepine was started, and it was discontinued because the aggression continued. So during the entire stay of this 15 days and then the 5 days before, he has received almost chemical restraints 50 times of PRN Haldol and Ativan, and he developed EPS and akathisia during that time. So for that reason, he was started on cogentin and propranolol for akathisia and cogentin for the EPS, extrapyramidal symptoms. So finally, he was discharged after 2 weeks of hospitalization. So total in the month, he was there in the hospital for almost 22 days in the hospital. So post-discharge too, the first week he had an outpatient psychiatry visit, and then the psychiatrist increased quetiapine to 300 milligrams 3 times a day, which didn't work. So the patient came back to emergency room again, and he was admitted to pediatric ICU this time. So admission number 3, he was started on intravenous immunoglobulin because they were concerned that he may have autoimmune encephalitis because he was having this aggression and there may be inflammation of the brain. So he was given the intravenous immunoglobulin for at least 3 doses of that, and then he was also on oral steroids for 5 days. During that time, there was prolongation of Q2C, and then the parents were concerned, so we have to cut down on the quetiapine, which is Seroquel. And he was started on amantadine, which Dr. Chintapalli has mentioned in her talk, that amantadine is an NMDA receptor antagonist, which is commonly used in Parkinson's disease, was also used here. It also is used in traumatic brain injury. It's also used in strokes, Alzheimer's, and Parkinson's and Huntington's. So we started amantadine, which actually showed some improvement in his symptoms. And then he was transferred to a specialized developmental facility for respite care. Respite care is usually offered for parents who has a kid with autism or intellectual disabilities that has an ongoing issues, and then the parents need some break so they can take the kid to the hospital, and then they can leave the kid for a week or so, and then that's called respite care. So the kid actually got a respite care, and then basically he was still denied from all the hospitals in the state because they cannot take care of him because of his aggression. And we're still trying to find a placement, a long-term placement for this kid, because the parents can no longer control him at home. And we tried everything, like having a home help, home evaluations were done. And finally the patient was discharged. So the most common things that you can see, the most common self-injurious behaviors in autism are hand hitting the head with the hand, and then skin picking are the most common symptoms that you see. The obsessive symptoms, picking the skin, hitting self on the objects, like hitting head on the walls. So these are the most common self-injurious behaviors you see. This was from the study that was done by Stanfield recently, from a study of 14,000 participants. This was published in 2020. Okay, so the reason that I mentioned about this case is because he has a stable life until he was 16, and then all of a sudden there is I don't know what actually what actually led to the aggression. He had this aggression, and then he was tried on multiple medications he has never tried before. But I don't know what worked, what didn't work, because there's so many medications that were tried. And still the kid did not go back to home. He went to a facility, a long-term facility. So autism management is a challenge. If the kid has aggression, obsessive compulsive symptoms, impulsive aggression, and impulsive behaviors from ADHD and anxiety. So you have to treat what is in front of you. Even the kid has a diagnosis of autism, always treat the comorbid conditions, always evaluate for if there are any acute symptoms, like, any ear infections, dental problems, or constipation. Because the kid cannot speak, then you have to help the kid, right? So always think about all these comorbid conditions and treat the kid. So this is a website which has tremendous amount of resources for parents. This Autism Speaks on. So if you have a kid that is diagnosed with autism, a new diagnosis of autism, always share this website if the parents can browse and learn. This is the best website to go and learn because it has plethora of information. Thank you, guys. Thank you so much for the opportunity. Thank you for listening. If you have any questions, I'm happy to answer.
Thank you, Dr. Srinivas. Thank you very much for the presentation about autism global perspectives, challenges in treatment and management. Thank you for your case presentation also. Very useful to the senior residents. Thank you very much. Now, I would like to introduce our another speaker, Dr. Professor Shefali Gulati, Madam. She will be talking about the use of technology in the management of autism spectrum disorder. And about Madam, she's a professor, coordinator for DM Pediatric Neurology Program and faculty in charge, Center of Excellence and Advanced Research for Childhood Neurodevelopmental Disorders. And she's a Chief Child Neurology Division, Department of Paediatrics, All India Institute of Medical Sciences, New Delhi, and associated with the President-elect Association of Child Neurology India for the years 2023 to 2025, INSAR, International Society for Autism Research, Global Senior Leader for India 2021 to 23, and she's a founder member of Association of Child Neurology 2002, and she's a chairperson Academy of Pediatric Neurology, Indian Academy of Pediatrics for 2021, and she's an executive board member Indian Epilepsy Society 2021. She's a co-convener Pediatric Epilepsy subsection IES 2020. And Madam won so many awards: National Award for Outstanding Efforts in Science and Technology Communication through Innovative and Traditional Methods in the month February 2021. And Sheila Wallace Award, first Indian recipient by International Child Neurology Association ICNA for 2014. And Fellowship Award by Faculty of Medicine, McGill University and ICNA 2010. Lifetime Achievement Award by National Neurology Chapter of Indian Academy of Pediatrics 2014. 4 All India Institute of Medical Science AIMS Excellence Research Awards for the years 2019, 2018, 2017 and 2014. 6th Dr. I.C. Verma Excellence in Research Award 2018. Amrut Modi Unichem Prize 2015 by Indian Council of Medical Research. Dr. S. Janaki Memorial Oration by National Academy of Medical Sciences 2016. Fellow NAMS 2016. Atal Swastha Bhushan Samman 2019. And 347 publications in various international and national journals, including NEJM and JAMA Pediatrics, etc. Thank you very much, ma'am, for being here. Dr. Shefali Gulati, ma'am. Thank you very much.
Thank you. Thank you, Dr. Jagadish, for too much. You said too much, actually.
Thank you.
One second. Thanks. I hope you can see my screen. Thanks for the opportunity for sharing. Can you see my screen, sir?
Yes, madam. Thank you.
Full screen? Yeah.
Yes.
Okay.
Go ahead.
Okay. It's very nice. Thanks for inviting me and allowing me to share the platform with so many experienced people from India and abroad. We just talk to you, touching how technology is touching us in how helping us in management of these children. So basically, I have no disclosures, and I dedicate my presentation to children and families with special needs. Basically, we have to understand from where technology can be helping us. From the screening and diagnostic tools to biomarkers management, and whether we can prevent it, how COVID-19 has changed the situation and the UN theme this year. Neurodevelopmental disorders, this was a landmark paper from India, which we had, in which I was a network coordinator and site PI. Dr. N.K. Arora was a team leader, and Dr. M.K.C. Nair was the PI. So we had, I just want one single slide from that we had studied neurodevelopmental disorders, including autism, and we found that 12% children in the age group of 2 to 9 years had one or more neurodevelopmental disorder. I want you to know this, And the next point, 21.8% had more than one neurodevelopmental disorder. So emphasizing the need to see for comorbidities, as one of my predecessors has already explained how many comorbidities can be there with autism. This was the first figure of its kind, 1 in 89. Well, I may tell you that the data we collected was in 2011, though the paper published is in PLOS Medicine in 2018. So because the prevalence is rising and now the CDC is giving a figure of 1 in 54, or this 1 in 89 in India was of 2011. So as it is, we all understand that you have problem with social interaction and communication, and the other domain is the restrictive, repetitive behaviors, focused interests, sensory issues, and along with it, so many comorbidities. We have to keep in mind their intellectual ability, their language, and their dependence. So basically, for screening and diagnostic tools, how we have coming, what is currently available and how technology is helping. Most of us are using the MChat for screening from 16 to 30 months, and from DSM-4 to DSM-5, which has been elucidated earlier by my predecessors, that now it is DSM-5 with calling autism spectrum disorder. So we have the new tools which are there. As a screening tool, we have socio-culturally sensitive tools. We have three. We have the neurodevelopmental screening tool from 2 to 9 years, part of the INCLIN study, being used for Rashtriya Bal Swasthya Karyakram. Then we have the ages and stages questionnaire, 2, which has been socio-culturally adapted for under 24 months. And this was an ICMR study, which we completed 1.5 years back. And this is an autism screening tool, which we have developed for less than 18 months. Then you have the diagnostic tools, autism, ADHD, epilepsy, and neuromotor impairments. Neuromotor impairments is a term used for all having CP or neuromuscle disorder or post-stroke, post-meningoencephalitic sequelae. So these were all initially tools, were INCLIN tools made for 2 to 9 years. And for autism and ADHD were DSM-4 TR based. Then in AIMS, we have expanded the spectrum of the age, and autism and ADHD tools have been modified and validated again on DSM-5 criteria. And epilepsy and neuromotor impairment are from 1 month to 18 years. And ADHD is also from 6 years to 18 years. Autism tool is now expanded from 1 to 14 years. Original INCLIN tools were 2 to 9 years. So this is the 11 question in the neurodevelopment screening tool. Then we have the ages and stages questionnaire, which has been having a good psychometric properties, and it is in English and Hindi. We can do regional translations, as in when anybody wants to have a partnership or I get some money for that. This is another tool we had developed less than 18 months, between 0 to 6, 6 to 12, and 12 to 18 to screen for autism, because even in the first year of life, we can suspect autism. And there was good sensitivity of even 90% to have picked at 12 months of age. We have done an internal validation study. We are seeking collaboration for doing an external validation study in various SAARC countries. Then this AIMS modified INCLIN DSM-5 based tool is published in PLOS 1. And it has good psychometric properties, and it also has a scoring. So it has been scoring, the scoring has been correlated with the CAR scoring. And there was this paper which Dr. Jeeson C Unni had mentioned about, in which we had done an elicitation procedure to see that CARs to improvement of 4.5 points would be significant to have a meaningful improvement in the intervention programs. Then because of the comorbidities, I'm just mentioning that we have the AIMS modified ADHD tool published in Neurology India. For the AIMS, the epilepsy tool is in epilepsy research. And in Frontiers of Public Health, you have the neuromotor impairment tools. And the original INCLIN tools have been used by the Rashtriya Bal Swasthya Karyakram, and the newer tools are in the process of approvals. How technology is coming is, it is very difficult to use tools in the practice. How will you use tool and then you see the age and you ask question and tick mark and calculate virtual domains are there. So we have made all that into one mobile app, Ped Neuro AIMS Diagnostic, freely available on Google as well as Apple Play Store. You can download, you can store your patient data also for the same. And then, now many advances are coming up. There are some machine learning by support vector machine. There are algorithms which have been made to prediction of ASD at 3 years of age have been developed. There is one alternative decision tree. They are using ADIR and using only few questions from that and trying to predict. Then now artificial intelligence is being used also by seeing the face scanning patterns based on eye tracking. A child with autism looks more under the, looks more under the right eye. And there are certain things like kinematic parameters like movement, hand movement, and total motor scores and all have been put it into using AI based thing to screen these children for autism. Coming to biomarkers, it has been mentioned to you that you have environmental prenatal factors and you have epigenetic factors and genetic factors which all lead to having a development of autism. And there is a increased paternal age is also there, and that could be because of germline mutations. There are a lot of environmental factors which are being studied. Why is it important? It's all we have to see what we are studying mostly are associations. For causative things, we have to have big cohorts of pregnant mothers following them up, children, they are born and then grown up into adults, then only you can have a causative thing. All these are association studies which are being done. We are trying to see whether we can prevent something, whether there's something strongly associated, so whether we can prevent these conditions. So we have found that maternal exposure to, for air pollution is there, pesticides, valproate is there, SSRIs, and even cigarette smoke is there. So all this is still being developed. We have studied and found that vitamin D and serum zinc levels were low in autism patients. And we had also studied for oxidative biomarkers, and we found that serum homocysteine and D-tyrosine levels, which was an abnormal glycation product, was higher in autism children compared to controls. Then we were studying for heavy metals, and we found that heavy metals were raised in mercury, chromium, manganese, and lead were raised significantly in children with autism compared to typically developing children. And we're trying to study various molecular, genetic, and environmental factors for autism and other neurodevelopmental disorders in a study just now about to start. Another thing, you had a nice talk on the gut, the GI manifestations. You have to, we analyzed the gut microbiota, and we found that there was a considerable, decline in the ratio of the firmicutes and bacteroides in the autism patients compared to their siblings who were as controls. And currently we have an RCT on probiotics going on. So we're trying to understand whether the gut microbiome, can be monitored, because and it will be helpful in children, looking at technology, helping and giving us cues to where can be the therapeutic targets. Then I told you about the advanced father's age, paternal age. So we're trying to study the sperm epigenome, and in this study which we have just now completed, we have seen that the poor sperm DNA quality and oxidative DNA damage plays a role, an epigenetic role when paternal sperms, and increases the risk of autism in offspring. Then there are a lot of studies which have been done on using structural MRI in trying to find out specific areas of the brain which have issues. There's a problem has been seen in certain areas specifically. Also, you're seeing on functional MRI. You're seeing based on functional MRI, it is based on the resting state or the task based. Then you have also seen DTI has given a lot of about the integrity, about the white matter integrity and specific localization in the tracts. Then this is something which has come up new recently is quantitative EEG, which has various bands of frequency which is there, and also the mu rhythm. The mu rhythm is there, which is correlating with the mirror neuron dysfunction, which is there in these children. So we have many studies are going on to see from as a potential biomarker. Even in this study which we had done on heavy metals, we did also quantitative EEG and saw that we saw that there was reduced spectral power and coherence in children with autism spectrum disorders. That's a potential biomarker to in these children. Then there's studies have been going on in correlation between EEG and MEG, and they have seen that you may have long range underconnectivity and local areas of overconnectivity in autism, which is there and has to be explored for further understanding whether there could be any therapeutic potential. Then eye tracking has come in a big long way, and there is a way the autistic children have decreased fixation to social relevant regions. So the studies have been shown, and they have shown to be predictive. So they are showing that autism can be picked in siblings of children with younger siblings of children with autism can be seen by eye tracking. They can be picked. So eye tracking devices are available. We also, along with University of Reading and Sangat and IIT Mumbai, we developed one screening tool for autism risk using this kind of technology. And also with University of Birkbeck for eye tracking assessment, early assessment in children with autism. Another study, we tried to study the emotional recognition ability of these children. We developed an Indian affective picture database and tried to see. And we found that happiness was the easiest emotion these children could see, and surprise and fear were difficult to recognize. These are important to understand so that we can help in intervention and help these children. This paper was, just came 3 days back, and the full paper is not available as yet. Only on 16th April it came, in which, this something at interest I wanted to put, because we keep talking about boys with autism, with females with autism have not been studied much. Now, in this study, which just came only 2 days back, on 16th of April, they have studied the functional MRI and genetic data, and they have tried to see to with respect to functional MRI with respect to a human motion, and they have found that they are reduced responses seen in autism females, and there is some problem in the striatal area. So all these may help us gain given potential therapeutic targets in these children and looking at these children differently. As regards management, we understand that there is an imbalance between the inhibitory and excitatory neurotransmitters, and there have been both genetic and non-genetic models of mice and rat have shown this, and there are various potential intervention therapeutic targets, and many drugs are there in the pipeline working for the management of specific issues and challenges in autism. Gut-brain axis, I mentioned earlier, it's important. There are two aspects to it. One is the leaky gut thing, and the other is the gut microbiome. There's another thing coming up to complicate this beyond this. There is a thing of gut immune endocrine brain axis. So they say that there is not only the gut brain axis, but the immune and endocrine thing is there. And there's one paper came recently about 2 years back, and they have suggested that you should see locally, you should specifically individualize the diet of a child based on various parameters which they have suggested. So something coming long up, this is coming in technology. With Sangat, we are collaborating to have this, and obviously, and Harvard Medical School and Manchester, trying to make a home-based intervention package for these children, because parents are, it's family centric, so this has to be important, and we are using technology in this, and we are using the video recording of the sessions with the parents to guide them further. Another very important use of technology is alternative augmentative communication. Most people end up saying, when will my child speak? They correlate language along with communication. They have to be told that communication has to be focused a lot. We keep focusing on the speech also, but also the language. So we have various devices which are there. We are also developing a mobile app currently for these children with ASC. Then AI-based, artificial intelligence-based interventions have been made. There are some computer-based games which are there, and they have made robots which are there. They have made semi-autonomous parrot-inspired robots or humanoid robots which are there, which will help in providing intervention to these children. We are just going to be starting a study on a human robot and trying to give intervention to these children. And we are also developing a prediction skill to improve the prediction skill, a robot toy with IIT. And we have already developed some augmented reality book, along with, to facilitate the eye contact in these children, and also getting a grid robot system made. There is a virtual realities, the child is there immersed. There's a interactive simulations are there based on the software and on the computer. So basically you may have either virtual reality or you may have augmented reality. So we develop these apps for reinforcement or based on the temporal prediction and spatial prediction in these children, and also for augmented reality. Augmented reality adds some digital elements to a live view. So, and also we have to keep in mind that autism also gets helped by compressive garments to for the severe proprioceptive dysfunction, and we also developed one weighted compression vest for reducing hyperactivity. Currently, transcranial magnetic stimulation is coming up in a big way in many things, although for long it has been used by psychiatrists for depression and many other conditions. And we have studied it in hemiplegic CP and in epilepsy, but now we have started a trial in which we are trying to see how whether it will improve the core functional deficits in autism spectrum disorder. And another thing which is coming, I mentioned to you, you either have environmental factors or you have genetic and you have epigenetics. Then you have the long non-coding RNAs which are there implicated in many neurological diseases. We are trying to study these in children with autism and seeing whether they get changed after giving TMS. So this is very important and coming up in a big way because they will be a good therapeutic model. Target would be, it will be a good therapeutic target. Something which is of the 2021 is precision medicine. What happened is that depending on the child's genetics, environmental and lifestyle factors, you have to individualize the medication. So basically when the Human Genome Project ended in 2003, after that they started studying, understanding various diseases and conditions, and then then you have for individual conditions, you had medicines coming out. Now it is not, for an individual patient, the medicines have to be tailored. This is how it is coming up. It is right now not applicable in autism, but with the research going on, it will be. And there is another thing is nanotechnology are there. Dendrimers are soft globular molecules which can give the drug or targeted gene delivery. They are being used in many conditions, and they have been used in CP till now. But autism, it is going to be a potential to be used. nothing gets end without a stem cell being talked about. There are various kinds of stem cells and all. They have paracrine effect as well, immunomodulatory. I just want you to know that out of the mesenchymal stem cells which have a potential role, currently there's no evidence which says that it will be beneficial. They are restricted only to strictly regulatory guidelines right now. Coming up beyond stem cells is something I want you to know, that is exosomes which are derived from mesenchymal stem cells. We are about to initiate a study in which we are going to be giving the exosomes derived from mesenchymal stem cells in a rat model of autism spectrum disorder, and try to see whether there is any improvement, because otherwise when it gives an improvement, then it is going to be a very big potential, and it's a part of the cell, so it will be a big potential. And to end it all, they have something like a pre-implantation genetic screening and pre-implantation genetic diagnosis, currently available only for thalassemia in our country. And why is not for autism? It is going to be a distant thing, but it has to come someday, because it's a complex disease, not fully understood. There are at least 50 associations for fetal origins of this disease. They are there, but we do not know. There are also epigenetic factors, and you have environmental factors, so it's a complex disease. And before I end, I want to mention something on screen time, because technology is giving you screen time, and with the COVID thing also your screen time is there, but screen time itself has been just shown that more than 2 hours per day in school age children has been shown to have autism like symptoms. And for a JAMA pediatrics paper, 12 months old child for more screen time had more autistic-like features, not autism, but not at 18 months. And there are guidelines by AAP regarding the screen time, which is there for less than 24 months. They don't recommend any. For 3 to 5 years, 1 hour, 6 to 10 years, 1 to 1.5 hours, and middle school children up to 2 hours. And this is taken, like most of the academics now are online because of COVID, otherwise nothing will move. So this is taken as beyond your academics times as this. And so as to we have used the technology to empower the professionals as well as parents pan India. We have this website www.pneuraims.org, where you have various drop downs for various neurodevelopmental disorders. We also have a development assessment made easy, and there is a 2-pager flyer with salient milestones, and we have a development assessment kit, and we also have a PowerPoints and videos of how to do a developmental neurological examination. And also we have all the training material for the training of master trainers for diagnosing and certify autism. We have had 4 workshops till now. We're going to have one more an online workshop in this near shortly. Then we also have bilingual learning resource materials for parents as well as professionals, and also conference proceedings and e-learning modules. E-learning modules are for professionals, and we also developed a book, a drug book, as a compilation of the drugs used for neurodevelopmental and neurological disorders. And this thing is very important. I feel they're all parent-centric. Autism is parent-centric. You have a parent's corner for patient information material, which is written, as well as videos for them. It is very important to make them understand, and they can download and use. And epilepsy is there. It's seen in 7 to 23% of children with autism, as has been told to you in a preceding presentation. So they have to be taught of how to do a domiciliary management of seizures and various things about seizures. And obviously about autism, we're trying to give them for adolescents, for the boys and the girls, how how it's a part of normal growing up, various organs, and there's a no-touch technique on the reverse side of the pamphlet. Then skill development and all. I think we as pediatricians, pediatric neurologists, developmental pediatricians, and other practitioners have to, other professionals have to see and holistically the child. And also these are the intervention booklets in which we have done a ABA, sensory integration and structure teaching. Everything is comprehensively, and it's marked for the patient by the therapist or what to do. So we have a basic primer, a detailed stuff for the parents to see. It's important for them to be told, and they have to understand. And they have to also understand, and we also have to understand, it's recognized as a disability, notified in 25th April 2016. And we initially now we have been certifying with INCLIN tool for diagnosing, and by scoring was by ISA. Now there is the process of replacing the old INCLIN tool by the AIMS modified INCLIN tool is in process right now. Till then, we're teaching both of them in the workshops. So this is one thing. And the quality of life of the child, the family, and the sibling has to be kept in mind. I heard the figures. We were talking about depression in children with autism and mothers, we had done a study in which 3/4 of the mothers had clinical depression of the mothers who have children with autism. So we have to teach them proactively coping strategies. That will be very important. And this is how it looks on the mobile. And in a part of a center of excellence, we are trying to develop a national registry of conditions, including autism, a national knowledge training center. Advanced diagnostics for autism, we are doing RACGH and whole exome, trying to develop, understand whether any genetic panels can be identified for our patient population, and trying to have for advanced therapeutics using virtual reality, robotics, artificial intelligence, and textiles for autism spectrum disorder, and gluten-free, casein-free diet and music therapy for them. We do also have a 24-hour helpline for these children, along with teleconsultation. Helpline is for anybody, teleconsultation is for our follow-up patient. COVID-19, we had done a meta-analysis, and we found that children with pre-existing ASD had a probability of worsening of behavioral symptoms. We need to make some, online intervention programs. Now that the second wave is also coming, I think we'll have to make some online intervention programs collectively with the Child Neuro Development Group and the Child Neurology Group and all as partners. We should develop something comprehensive for our parents to help them. And other thing, problem with COVID-19 will becomes to explain to them how we're going to do the social distancing and the mask use. So this becomes an important thing. And to am ending it by talking about the UN thing is inclusion in workplace, challenges and opportunities in post-pandemic world. We have to use the technology to train them, and we have to identify the skill development of these children. And the mother of this child had told me that equity is important. This child actually had many hobbies, but ultimately wanted to go into, he's done 10th class from open school, and he's done by online, and then he's also online getting trained. He's in baking. And so that is how you can use technology in doing that if they don't feel like going and meeting. And their mother showed me the slide in which equity is important, what they're asking for. And there's also, we have to identify those children who are doing good and felicitate them. That's how we did. And that's why with the National Trust, we had asked for online entries from all over India, and we had 140 entries, and out of which 7 children were felicitated, including the one who was making this Ganesha, including the one who was a Limca book records, somebody who has an Olympic gold medal who was making this Kundan and all. So we have to understand technology has to be used as an aid. I'm very grateful to all the families and children who have participated in the project, and all our national and international collaborators. Einstein said that everybody is a genius, but if you judge a fish by its ability to climb a tree, it's lived its whole life believing it's stupid. So one has to be very clear of differently able can challenge the word. Mozart said he doesn't like the music he creates, but he likes the silence in between. And when the world says give up, hope whispers, try it one more time. So we should give always positiveness to our parents and families. Thank you so much. This is AIMS Lit Blue in 2015.
Thank you, ma'am. Thank you very much for your detailed explanation about the department and its services in Center of Excellence in Advanced Research for Childhood Neurodevelopmental Disorders. You are really doing a lot on behalf of the your institute, ma'am, National Institute. Thank you very much for sharing your total updates from the All India Institute of Medical Sciences, Department of Neurology. Thank you, ma'am. Thank you very much for your detailed explanation up to date. Thank you.
Thanks.
Good afternoon, everyone. I am Dr. Jagadish, consultant neonate and pediatric early interventionist in neurodevelopmental disabilities. I'll be talking about the current evidence practices. All of you know that the autism spectrum disorder will be having so many core symptoms, including epilepsy, immune dysfunction, OCD, and social anxiety problem, language disorders, motor apraxia, sleep disturbances, attention deficit and hyperactive disorder, GIT and aggression, social impairment, so on. So how to choose therapy for a child with autism? After a child diagnosis, which therapy is very useful? What therapy really it involves that? And what it really involves? Is it very cost effective? And is the therapy safe? Is it harmful? Or is it a scientific evidence-based practice? Or who is the right professional to whom we have to approach? And who is the right therapist? And how to select? There are so many question marks. So here, actually, we need to evaluate all relevant domains like gross motor, fine motor, personal, social, speech, language, sensory issues, all the domains we need to involve. And we have to, evaluate. So here we need experienced multidisciplinary team professionals. So who are the team professionals? Like multidisciplinary pediatrician and pediatric neurologist, pediatric psychiatrist, and GP, that is general physician and family physician, developmental or behavioral pediatrician, occupational therapist, speech language pathologist, physiotherapist, behavioral analyst, and special educator, clinical psychologist, and rehabilitation psychologist. There are so many people who really involves from A to Z of this, from assessment, diagnosis, and intervention part. So what are the evidence-based interventions for children with autism spectrum disorder? So before that, we need to catch these children at very young and intervene early. This is what the early intervention really plays a significant and crucial role. So the rationale of this presentation is selection and implementation of evidence-based practice interventions. So there is a need for evidence-based interventions. Why? Because identifying effective medical and behavioral treatments for the neurodevelopmental disabilities is plagued by the use of unsupported and oftenly controversial interventions are happening. So like there are certain, on controversial, intervention programs. Let us see that. So the basic principles of effective early intervention programs are: once the child's diagnosis done, immediately as soon as possible, intervention has to be initiated, at least 24 or 25 hours per week for 12 months per year. And here the low child and therapist ratio is very important for individualized early intervention program and individualized education program. Here we need to involve the parents as the partners of the therapeutic intervention program. Of course, the child's peer group interaction also should be facilitated. And here we have to use the assessment-based curriculum. And evidence-based practice has become the current benchmark nowadays for the professionals in medicine, psychology, education, and other healthcare fields. Evidence-based practice includes a combination of the best available scientific-based professional expertise and understanding of client traits. So here we have to review the scientific research. This is very important because it gives a foundation for evidence-based practice and for decision-making regarding the intervention programs. Evidence-based practice is informed by the professional expertise because it helps to judge the interpretation and application of the available research evidence. Evidence-based practice, including consideration of individual characteristic traits. This is very important, like strengths of the child, concerns of the family, and values and preferences. Family, the professional team, and also available community resources we need to consider before giving the intervention program. And importance of the systemic research review also is playing very important role. And not all evidence-based practices are effective for the children with autism spectrum disorder. Earlier, the patients or the parents used to go to the doctor or professional. But nowadays, most of the educated parents, they are approaching the internet or Dr. Google. So here, one more thing is no treatment is autism spectrum disorder, works for all children. Like all visions are not asthma or all hyperactivity behaviors are not ADHD. So here also no treatment in autism works for all children. And please do not rely on Dr. Google. You may develop cyberchondria. So there are certain complementary and alternative therapies. Let us see the biological treatments. So the biological treatments including dietary modifications, vitamins and supplements, chelation therapy, melatonin, antibiotics, antifungals, immunoglobulins, and hyperbaric oxygen. And when it comes to the non-biological treatments, including auditory integration therapy, behavioral therapy, craniosacral manipulation, music therapy, yoga, and sensory integration therapy. And psychosocial intervention classification, including applied behavior analysis and cognitive behavioral therapy, CBT, supportive psychotherapy, speech language and communication therapy, special education training, occupational therapy, which including sensory integration therapy, pharmacotherapy, and nutritional therapy. So there are certain non-evidence-based interventions which are aromatherapy, soft tissue manipulation, hippotherapy, that is horseback riding. They say that it improves coordination and balance and posture of the child. And yoga therapy, pool therapy, craniosacral massage, and music therapy. So we have to bridge the gap. This is very important for generalization. So autism interventions, there should be a standardized criteria or protocol. Like it should be evidence-based effectiveness and clinical decision-making. And it should give values and preferences of the families. That means we have to consider the families' values and preferences before developing a program. And including, like capacity of accurately implement an intervention program. The profession should have a capacity. Even from the family side also, we should have the capacity to implement the therapeutic intervention program. So there are 27 evidence-based practices as per the 2014 evidence. So antecedent behavior and antecedent-based interventions, cognitive behavioral intervention, differential reinforcement, discrete trial training, exercise, extinction, And functional behavioral assessment, functional communication training program, modeling program, naturalistic interventions, parent implemented intervention programs, peer mediated instruction program, and picture exchange communication system, that is PECS, and pivotal response training, prompting, reinforcement, response interruption or redirection, scripting, self-management, social narratives, social skill training, structured play groups, task analysis methodology, technology aided intervention or instruction, time delay, video modeling, and visual supports. So if you look at the theory of behaviorist, we may not know what goes on inside the brain, but we can certainly definitely see what happens on the outside. Let's measure behaviors and learn to modify them with behavior reinforces or rewards. If we like it, reward it. If we don't, just punish it. This is a book called by Eric Jensen that is teaching with the poverty in mind. So applied behavioral analysis, that is ABA, it is a process of applying behavioral techniques or principles to modify or to change the specific behaviors. Generally, it emphasizes prevention and remediation of a problematic or challenging behavior. Start before the age of 5 years for effectiveness, and age range supported by the evidence 18 months to 9 years. And applied behavior analysis delivered through as little as 1 hour per week of parent training program, which will be very effective in reducing the problematic behaviors and building social communication in children with autism or spectrum disorder. So ABA is low-VAS therapy, discrete trial training, pivotal response training, functional communication training, modeling, reinforcement, and naturalistic observation. So under discrete trial training program, in this, a discriminative or a differentiated stimulus is presented, so the child will respond, and the child receives a consequence, that is a reward or reinforcement, which is based on the response to encourage the skill acquisition. So it is a one-to-one instruction approach. The areas where we can taught this is behavioral as well as communication skills can be developed. It can be taught in small repeated steps at each trial, like positive praise or tangible rewards are used to reinforce or reward the desired skills or behaviors. And age range generally from 2 to 9 years we can give. And pivotal response training, PRT, the basic principles of ABA only will be applied here. This will be developed on the basis of child's initiatives and interest. So the main skills which we can develop here are social skills, play skills, language skills, communication skills. Very useful for 3 to 9 years of age. And functional communication training program. Socially appropriate behaviors generally are taught as replacement for problem behaviors. First, the problem behavior should be analyzed to determine its communicative function through functional behavioral analysis. And then a replacement behavior is taught to take its place. This is very useful for the children from birth to 21 years of the age. And modeling, definitely it will provide a kind of demonstration of the good behavior, which will be combined with prompting as well as reinforcement. And reinforcement, it is if a consequence increases the probability that a behavior will occur again and again, it can be said to be as a reward or a reinforcer. In this, again, there are 2 types, positive and negative. Positive means offering incentives to reward a good behavior like token economy, social praising, primary rewards, or eatables, or activity rewards. Negative reinforcement means it involves removing an aversive stimulus to reward a behavior. Naturalistic intervention is nothing but environmental arrangement can be done by interaction techniques. Here, the therapist or the parents will interact with the child, and behavioral strategies that are used to promote appropriate communication and social skills. Very useful from birth to 9 years of the age. Cognitive behavioral intervention program. Interventions will emphasize teaching children to monitor and manage their own thoughts or thought process or feelings or emotions and behaviors. Generally will be applied from the age 6 to 18 years of the age. And augmentative and alternative communication for expressive communication deficits, because children with autism will be having this problem. So sign language to picture systems, electronic communication devices can be used for this augmentative and alternative communication modes. And exercise or physical activity, the child with autism spectrum disorder will be having attention deficit and hyperactivity disorder as a comorbidity. So exercise or physical activity definitely will decrease the hyperactivity behavior and to increase the attention and concentration span. And joint attention intervention program, this is nothing but to teach a child to respond to the non-verbal social bits of others. Example, pointing to the specific object, showing items or activities to another person in the home environment, and following the visual eye gaze or visual gaze. This will be very useful from birth to 5 years of the age. And parent implemented intervention programs, here we need to taught the parents to provide individualized early intervention program to their child to improve or to increase a wide variety of so many skills and also to decrease problematic behaviors. Here parents learn to implement practices in their own home environment or community through a structured parent training program has to be designed by a therapist or a doctor. Peer mediated instruction and intervention program, it is to acquire new behavior or skills and communication, social skills. Like in inclusive education, now everyone is talking about inclusive education. And this will be very useful for the children from 3 to 14 years of the age. And integrated play groups, nothing but to promote socialization as well as imagination skills to play with non-disabled peer group. So it will create an appropriate playful environment and also selection of the particular materials or objects. And picture exchange communication system, that is PEX. It is nothing but it is based on the verbal behavior as well as applied behavioral analysis using the pictures. PEX it also has been used to decrease the undesirable behaviors. So for children with expressive language difficulties, children are trained to exchange the pictures, cards for desired items, for which the trainer or pairs. So trainer will pair or joins with a verbal label for that particular item, which will be very useful for the children from 3 to 12 years of the age. So these are the picture cards or PEX cards. Then prompting. These are generally given before or as a learner attempts to use a skill. It may be a verbal prompt or it may be a gestural prompt or it may be a modal prompt. Very useful from the children age that is 2 to 22 years of the age. Then early intensive behavior intervention program. It should be individualized and more comprehensive, and it can be done even by underqualified or even a trained professional, can be done at home-based or institution-based programs. Preferably, we can include the parents also in this program. Parents can be trained in this program, and minimum 20, maximum 35 sessions per week should be carried on. And for borderline and mild autism spectrum disorder, scripting will be very useful. So scripting, it involves developing a verbal or written script about a specific skill or a situation in which it serves as a model for a child. Usually practice repeatedly before the skill is used in the actual situation. Then self-management techniques are very useful for the children with borderline as well as mild autism spectrum disorder, because they can monitor themselves, they can record their own behaviors and reward themselves. And social skill groups are nothing but which including like 2 to 8 children, including a therapist or a teacher or a parent. Most skills, these meetings include instruction and role playing and practice. Speech generating devices are nothing but which will produce either synthetic or digital speech for the user and can be used with graphic symbols and alphabet keys. Task analysis generally used for self-care, work task, as well as academic behavior, communication, play, and social transition related skills. Time delay, which will focus on fading the use of prompts during the instructional activities. So commonest skills can be taught with the time delay or academic skills, communication skills, play skills, and social domains. So it is very commonly used for the children from 6 to 11 years of the age. And the TEACH, that is training and education of autistic related communication for handicapped children. This is a structured education model which is based on the culture of autism. So here we can use this from birth to 18 years of the age. In this, visual cues are used. And video modeling is also very, very important technique. With this, like self-modeling, point of view, video modeling, and video prompting, we can use for the children with autism spectrum disorder. Visual prompts are nothing but which including, pictures, written words, objects within the environment, arrangement of the environment, visual boundaries, labels, and timelines and scripts. All these are very, very useful for the children with, autism spectrum disorder. And sensory integration therapy. That is principles of neuroplasticity if you look at. So we have to either use it or lose it, use it and improve it. Specificity is very important. And here in the sensory integration, repetition matters, salience also matters, and age of the child matters. Transference is very important, and interference and time also matters. So these are the very basic principles for the neuroplasticity. And when it comes to the pharmacotherapy in the children with autism spectrum disorder, risperidone and aripiprazole commonly used for the children who are having irritability. Methylphenidate is nothing but a psychostimulant which is very effective in reducing symptoms of inattention and hyperactivity in children with autism. And gluten and casein-free diet, you know that already background, which is commonly found in wheat, rye, and barley. And casein very commonly found in dairy products. Gluten and casein break down into opioid-like peptides. So here there is a theory called leaky gut theory. So excess opiate activity in central nervous system results in the symptoms of autism. So there is a Cochrane review in 2009. It shows very insufficient evidence. So it is strongly recommended that a physician should test for food allergies prior to beginning this diet. But sometimes it is very stressful to the family members regarding the diet selection to a child with autism. And chelation therapy agents used to bind and remove heavy metals from the body, like lead poisoning. So here there is an hypothesis that the children with autism have mercury toxicity. Actually, in 1998, MMR rapidly debunked theory, that is Lancet theory. So here it is not because of the vaccination, but chelation therapy, a potentially dangerous treatment for the heavy metal poisoning, including mercury poisoning. Melatonin, ma'am already explained, that hormone produced by pineal gland, available as a nutritional supplement. Sleep problems are highly prevalent in children with autism. So evidence of abnormal melatonin regulation in autism. So clinical studies have shown some kind of benefit. Secretin, it is a GI, that is gastrointestinal peptide hormone, that has received attention as a potential cure for autism. Here, controlled research indicates that secretin has no benefit for individuals with autism. Vitamins, dietary supplement therapies, carnosine, thought to have antioxidant activity and role in production of neurotransmitter, that is GABA. So definitely it will lead to hyperactivity behavior. And dimethylglycine, which decreases the inflammation and increases the immune function. An earlier study reported improvements in speech-language communication when children with disabilities were given dimethylglycine. Omega-3 fatty acids, which are neuroprotective benefits. Preliminary studies have shown mixed results, but promising results for improving behavior in children with autism. So generally thought to be safe here by using this omega-3 fatty acids. Some studies show decreased levels of omega-3 fatty acids in autism children. But the main side effect is gastrointestinal upset. And probiotics definitely indicated gastrointestinal bacterial and fungal growth, and bacterial effects of probiotics have been shown in irritable bowel syndrome and acute gastric GIT problems and urinary tract infection. But very meaningful research has not been done in this area. Generally thought to be safe in the absence of immunodeficiency and assuming intact gut. And vitamin A, that is cod liver oil, which definitely improves the immune function and vision of the child, but can cause the hepatotoxicity and increases the intracranial pressure. Vitamin B6, that is pyridoxine, advise the parents about the risk of B6 toxicity, that is peripheral neuropathy. And magnesium toxicity, that is nothing but changes in the mental status, gastrointestinal upset, muscle weakness, respiratory depression, hypotension, and erythemiasis. And vitamin B6 and magnesium generally safe, but toxicity may occur at elevated doses. Vitamin B12, that is cobalamin, we can give this intramuscular in conjunction with oral folinic acid to counteract to decrease plasma antioxidant concentration. Okay. Vitamin C shown to decrease the stereotypic behaviors in the child with autism in double-blind studies, placebo-controlled study that was never replicated, but the toxicity causes nephrolithiasis, there is kidney stones and gastrointestinal upset. Hyperbaric oxygen therapy proven effective for treatment of gangrene, carbon monoxide poisoning, and no evidence to support this. Stem cell theory. So here in stem cell therapy, no guarantee that the stem cells used in this therapy are even human sometimes. Antifungal agent therapy, hypothesis that bacteria in the gut cause autism. And since antifungal medications can eliminate bacteria, they believe they can simultaneously cure autism, but potentially harmful. Raw camel milk, there is no scientific research that upholds claims that raw camel milk is in autism cure well. So there are certain bleach therapies, hypothesis that bleach can eliminate bacteria, parasites, yeast, and heavy metals, and consequently eliminate ASD symptoms. So this is also not evidence-based. Transcranial magnetic stimulation is currently used to treat mental illness, including depression and schizophrenia. So here one more is the evidence that RDI, that is very, very important relation development intervention program is often described as the missing piece of the puzzle in the treatment of autism spectrum disorder. It is a cognitive developmental approach that works to increase the neuronal connectivity in the individuals with autism. And these are the books, that is RDI book, Relationship Development Intervention Program. And regarding the children with sleep problems in autism, definitely already Madam and Sir already explained the speakers. I don't want to go in detail. But for the parents, yes, it is very important. Common areas of concern are the children with autism parents. Generally, they feel burden and everyday, day-to-day responsibility of caring the child with autism. And parents may feel pressure to become an autism expert and learn everything overnight. And the parents may worry about the child and family future. And they may have difficulty in finding balance and time to manage household tasks and other children daily activities, etc. And the children parents may be less inclined to share their feelings. They may become stressed about the family's finances and the unknown of the situation. They may develop other problems like stress and anxiety that can affect their work life. So please do seek professional advice immediately upon seeing the red flags. When you identify the child with red flags or developmental deviations, immediately you need professional advice. Don't ignore or avoid the issue. And do not blame yourself. Do your research on the best of kind of therapy, what suits to your child. Do ensure consistency of approach in your home and in the therapy. This is very important. Do not give in to tantrums and behavioral excuses or excesses. Do not rearrange your whole life around your child. Do have open discussions with your child's behavioral analyst or professional. Explain your desired goals and how you believe your child is progressing. So here, the extreme aloneness during the early life causes autism. Everybody knows that. Autism to be caused because of the poor interaction offered by the parents and the caregivers, as Leo Kanner very clearly said in 1940s. So please avoid the toys and electronic gadgets and screen time and aloofness. Human interaction has to be facilitated. That is very important. And do learn to reinforce positive behavior. Be patient and stay positive yourself. Take responsibility. Be a leader. Learn. Be an expert. Think critically. Speak with authority. Be proactive. And you have to document yourself about your child's program and collaborate and be a team builder. Educate. Be voice of your child. And what we really need is holistic approach with love and compassion. And we have to involve the family because the family strength is very important for the child development. Innovative cultural related and habitation models also we have to incorporate. So thank you very much. And here Indian Academy of Pediatrics has now published evidence-based guidelines to help doctors and families to manage neurodevelopmental disorders. Thank you very much.
Yes.
Yes.
Thank you very much, Dr. Jagadish and Dr. Pavan and all the team members of your institution for holding this awareness program and joining hands with the neurodevelopment chapter and with the neurology pediatrics as well as with Telangana IAP. And it is indeed, you have brought all the giants of autism, working on autism together to give new information, and it is very, very updated information because, as I said, professional learning is the paramount importance because autism is a very complex matter. It is not like, you know, diagnosing and giving a treatment and it's over. It is not. These children will have to be detected early, have to be followed up with a lifespan approach till we find that the children are gainfully employed. This is one. And second is that every parent must have their parenthood. And this is the responsibility of every pediatrician. And hence we have to augment our work with information and deliver it for the productivity of the child. So I must thank you all for arranging this webinar and thank all the participants for being with us and all the speakers who have given their efforts to give us new information. Thank you very much.
Thank you very much, ma'am, for your valuable words during the wind-up time. Now, Dr. Srinivas from Arkansas speak few words about the webinar. Yeah.
So thank you so much, Dr. Jagadish and all the speakers, and thank you all for organizing this webinar. And I think this webinar has broadly enhanced the horizons for everyone about autism and challenges, and then management of autism with all the medications and behavioral treatments. I think the key to autism is basically
Okay. I will do it. Right.
Early identification and early intervention are the key strategies for managing autism. And I think the speakers, every one of the speakers actually emphasized on that. Thank you again, Dr. Jagadish, for organizing. Thank you, everyone.
I request Dr. Jeeson sir to speak few words.
Dr. Jagdish, you have been doing this. Last year you did a good program, and this year it's even bigger. I think this time you've had a galaxy of speakers. 4.5 hours was too much. And everyone, I think had 90 or 100 people sitting through for 3.5 to 4 hours, which was really good. This year, I think we've given a real thumping awareness programs all over. I mean, the neurodevelopment chapter under Dr. Shabina and Dr. Kawalji, they've got so many programs to this month. And I think there's been a lot of awareness programs. Parents are involved, all the therapists are involved. It's been a great month for autism awareness. And this program has sort of been another cog in the wheel. It's done a great job. I think all the speakers were excellent. You've chosen your speakers really well, and I hope all those who attended were benefited by it. Thank you so much for this program.
Thank you very much, sir, for your inspiring words. Now, I would like to thank the eminent speakers from India and abroad for making this virtual webinar happen successfully. I thank individually Dr. K.S.Multani, National Secretary of Indian Academy of Pediatrics, Neuro Developmental Chapter, Professor Dr. Shabina Ahmed, National Chairperson, Neuro Developmental Chapter of Indian Academy of Pediatrics, Dr. K Pavan Kumar from Paediatric Academy of Telangana State is a secretary, and Dr.S Srikrishna, Professor, Head of the Department of Pediatrics, Apollo Institute of Medical Sciences and Research, Dr.Lokesh Lingappa, Pediatric Neurologist from Rainbow Children's Hospital, and Dr. Ramesh Srinivasan, Pediatric Gastroenterologist and Hepatologist from Apollo Hospital, Jubilee Hills, Hyderabad, Dr. Meenakshi Chintapalli, Behavioral and Pediatric Developmental Pediatrician from United States of America, Dr.Jeeson C Unni, Senior Consultant, Aster MedCity, Kochi, and Dr. Shefali Gulati, Chief, Child Neurology Division, All India Institute of Medical Sciences, Dr. Srinivasa Gokarkonda, Child and Adolescent Psychiatrist from Arkansas, United States of America. And I thank Paediatric Academy of Telangana State and Paediatric Neurology Chapter of Indian Academy of Pediatrics and Neuro Developmental Pediatrics Chapter of Indian Academy of Pediatrics for associating with us in this international virtual webinar. And I would once again like to thank you for your valuable time and spreading your knowledge of expertise. I thank you very much. And also I thank the audience, because without the audience, this webinar will not be successful. Thank you, audience, for your registration, participation, as well as making this event as a successful event. Thank you very much. And I thank my technical team for running this program continuously without any errors. I thank you all. And finally, it is also a chance to rethink our systems of education and training to ensure the persons with autism spectrum disorder are afforded opportunities for realizing their potential. The pandemic crisis has created new obstacles and challenges, but efforts to reignite globally to offer an opportunity to reimagine the life of children with autism, to make diversity, inclusion, and equity a reality. Thank you, one and all. Stay home, stay safe, and God bless you. Thank you very much.